Welcome to the 15th Asian Telemedicine Symposium, ATS. My name is Kudo from TEMDEC, Telemedicine Development Center of Asia, Kyushu University Hospital in Japan. I am the member of the organizing committee of the symposium. ATS was started in 2007 to promote the exchange of information and activities on telemedicine among physicians, technicians, and coordinators from various countries, mainly Asia, and have been held annually. It has been organized in Japan, Korea, Thailand, Vietnam, Malaysia, Philippines, and Taiwan. And this year, we were able to hold this event in India for the first time. To our great pleasure, the Asian Institute of Gastroenterology, a world-renowned medical institution in the field of endoscopy, hosted the conference. For start the symposium, I would like to introduce Mr. Satya, a head of academic cell in AIG and also one of the committee member of this symposium. Satya, please.
Yeah, thank you, Ms. Koriko. And first, we would like to thank TEMDEC for giving us this opportunity to organize this 15th Asia Telemedicine Symposium from our institute. We have been eagerly waiting for this. In fact, we wanted to have it as a physical meeting, but because of this ongoing pandemic, we could not do a physical meeting. But with all your support, we are able to organize this on a virtual platform, and we have very good speakers from all over India, and who are all very keen in telemedicine, developing telemedicine in this part of Asia. And I hope all our team members will enjoy the lectures and update their knowledge from this telemedicine event. So, for the first session, I request Dr. Pradeep, who is heading the Surgical Gastroenterology unit at our institute, to take over the first session. Dr. Pradeep.
Thank you. Can you hear me, Satya? Can you hear me, Satya?
Yes, sir.
Morning, everyone. Good morning and welcome to all the delegates and faculty to this Asia Telemedicine Symposium. All of us have gone through and still going through the COVID pandemic and have seen the downside of the pandemic. But one positive thing about this COVID is we all have adapted to the digital communication in our day-to-day life. Whether it is education in schools or colleges or work from home or even conducting virtual conferences. But healthcare industry, which was reluctant to accept the telemedicine initially before COVID, now started accepting this in patient healthcare systems. Patients and healthcare professionals often complained about the lack of physical presence, but now, post-COVID, they started accepting the telehealthcare and appreciating the benefits of teleconsultation sitting at your own place conveniently. There are no geographical boundaries to consult a specialist. You can consult a specialist across your country. You're sitting in India, you can consult someone in USA, either in Mayo or John Hopkins. So, and not only that, even the images can be viewed and opinions can be given by the specialist from anywhere in the world. The acceptance of telemedicine opens up new frontiers to take the healthcare delivery to rural area where doctors are not available. Even not only in healthcare delivery, even in health education, where there is shortage of medical teachers, this telemedicine facilitates to bring the students and the teachers together on a single platform wherever they are located. This can impart high quality medical education to the medical students and trainees in an era where good quality teachers are lacking. And today we have luminaries in this field of telemedicine with us, and let us hear their experience and vision in the next 1 hour. Satya?
Yeah, now, thank you very much, sir. Now we request Dr. Tomohiko Moriyama, sir, to just deliver his opening remarks.
Hey. Thank you, Satya, for your kind introduction. Hello, everyone. This is Dr. Tomohiko Moriyama from TEMDEC. As a new director of TEMDEC, I'd like to show a brief comment to all you guys. Till last year, the first this opening remarks will be made was made by Professor Shimizu, but he retired from his position last April, and now he is a vice director of Kyushu University. But still, he is involved in our telemedicine project. Okay. Anyway, I'd like to express my sincere appreciation to AIG members first. Still, we are in a tough situation. They made a great effort to organize this symposium. It is my great pleasure to meet all of you even in the virtual. But tough times always bring us great opportunity. As you know, we have to expand our telemedicine project not only in Asia but in the world. Through this pandemic, many people, including medical staff, are being familiar with telecommunications. It is a very good opportunity to us because we have numerous number of experiences and knowledge of telemedicine. Now is the time to share our knowledge and experience with global friends and medical people for expanding the telemedicine activity. This time, the AIG is a host of this telemedicine. They have a lot of telemedicine experience. They do a live demo of endoscopy 24/7. Actually, it's really amazing. So I'm so excited to learn from them, and also would like to learn from our friends in this symposium. They will show us their experience during this pandemic, what they did and what they felt, and what they would like to do in the future. So I'd like to enjoy this symposium with all of you guys. Thank you.
Thank you, Tomohiko Moriyama. Now I will introduce Dr. Nageshwar Reddy, who is currently the chairman of Asian Institute of Gastroenterology. He is a past president of World Endoscopy Organization. He is a luminary in the field of endoscopy and gastroenterology. He graduated from Kurnool Medical College, and subsequently he did his post-graduation from Madras Medical College. Then he did his DM Gastroenterology from Chandigarh, PGI. His main area of research used to be the GI endoscopy, particularly therapeutic pancreatic biliary endoscopy. He has published more than 700 papers in national and international journals, and many chapters and textbooks of gastroenterology. And he was a Padma Shri awardee and also Padma Bhushan awardee. And also he received BC Roy Award from the Indian Council of Medical Council in 1995. He has been elected as an honorary member of the American Society of Gastrointestinal Endoscopy. He's a Master Endoscopist Award from ASG in 2009. And then he received the ASG President's Award, American Society of Gastroenterology, that is DDW Crystal Awards in 2020. And he is also awarded the Fellow of American Gastroenterology Association in 2020. And he is awarded a prestigious Rudolf Schindler Award by ASG in 2021. And I think that these awards can go on and on. And so it's my privilege to present Dr. Nageshwar Reddy to August gathering here. Dr. Nageshwar Reddy, please.
Thank you, Pradeep. Before I actually start my talk, a few introductory remarks. On behalf of the faculty of AIG, I'm extremely grateful to TEMDEC for giving us this opportunity to be a part of this very important symposium. In fact, I remember in 2007 when I met Professor Shimizu, I think it was in Korea. He was talking about this experience and he was doing the first conference there in Korea. Since then, he's been introduced to our faculty, and Dr. Satyanarayana, Mr. Satyanarayana here is almost a doctor because he knows a lot of medicine, has subsequently taken it up very highly as part of the committee member of TEMDEC. He has been very actively promoting this from the AIG part, and his team of others including Mr. Mohan, Sushil and others have come together for this conference. Satya has done a fantastic job in putting together this very important conference, and looking at the program and the type of speakers is able to get together, it's extremely impressive. We are grateful. In fact, I was a little surprised that Shimizu had to retire so fast. He doesn't look old at all, but I think he's done a fantastic job in propagating this in Asia countries, and I'm sure Dr. Moriyama is going to continue the tradition. Knowing him, I realized that the same energy, the same level of commitment would be there, and TEMDEC would become a very important concept, not only in Asia Pacific region, because whenever I travel in Europe and in United States, they keep asking me about TEMDEC and how transmissions are done. So, I think it's going to be an important example of how telemedicine, and especially in this era of COVID, is going to progress. So, thank you again for giving us this opportunity. So, let me start with my talk first, and this is on telemedicine experience during COVID-19 pandemic. I think COVID-19 pandemic has been an important lesson for us to how this could be properly utilized, and I think it came at a very appropriate time for the concepts of TEMDEC to be utilized. The change, of course, is very visible. Look at this, how COVID has changed the outlook for telehealth. It has shifted the use of telehealth about 11% just before COVID to 76% interested in using telehealth going on. Phenomenal shift, which has not occurred in medicine for a very, very long time. I think this is very obvious. Let's look at historically. In April 2020, governments across the world, especially in India, started implementing lockdowns. Access to physical healthcare services was suddenly halted, and telemedicine came to the rescue. If you look at the volumes of telemedicine, you can see in our overall it was extremely low in January, but come March, April, when there's a peak of the first COVID pandemic, 38%, extremely high. And as we go along, it stabilized now that 38% usage is 38 times higher than before the pandemic. Usage is there now, and it's going to remain in this, I think, for a very long time because of the continuing pandemic, and also because people have now got used to and know the utility of telemedicine. Of course, regulators have also made it easy to have telemedicine. In fact, multiple technologies can be used now to do telemedicine consultations and all. In about 2019, telemedicine was almost considered illegal. You couldn't prescribe medicines to the patient just on a video call or a phone call. But look how it has changed completely. The telemedicine practice guidelines have come now, and these have got stabilized. You can do video based, you can do an audio based, and you can do in WhatsApp chat, text chat based. All these have now become legalized so that it becomes much more easy to practice telemedicine, and especially I think what is picking up is WhatsApp text chat based telemedicine, because that's the easiest for people to understand and to do it from their smartphone. So, I think there's been a sea of change in this area, and regulators in many countries including ours have now made it very easy to practice telemedicine. It's believed that United States, even if physical medicine comes back, telemedicine is still going to be a chunk of how medicine is practiced, because the insurance companies have now accepted it, and that's very important. It's going to be a real game changer. Also, there are some specialties where telemedicine is especially going to be more useful. These are specialties which do not require actually physical contact. And you look at this, for example, psychiatry, endocrinology, rheumatology. These are specialties where you don't have to physically examine the patient, and these are the areas where telemedicine has not only been used to the maximum, can become potentially a permanent fixture in these cases. And I think this is something that has changed in this. In fact, I think the practice of psychiatry has changed forever with COVID and telemedicine. What has been AIG experience? So, when AIG, the first COVID hit us, just before that we are not very strong advocates of telemedicine, basically because we believe that physical examination was extremely important. But with COVID hitting us, we decided that telemedicine was going to become a very important component of our practice. There are three areas here that I'd like to emphasize what we took over. One was for the patients, the actual telemedicine consultations. Other was for e-consults that we are giving for the healthcare participants, and of course for education, tele-education became very important. And of course, we had a tie-up with the Mayo Clinic Care Network, where we could do this e-consults, where difficult cases were often discussed with very high-level consultants at the Mayo Clinic, and we could come to a consult. We in fact started a virtual OPD with advanced online video consultation, and this was started as a separate segment of our outpatient department, where we set up these consultation chambers. Doctors would come there, and then along with talking with the patients on video, have some of the features of tests and all also brought back, and then of course we could give them the correct advice. But even before telemedicine actually started in COVID, we are actually using it in a smaller way, especially for following up outstation patients who had surgeries. If a patient had a surgery and he wanted to follow up with us how he was doing, so coming all the way, say from different parts of the country, he could just log on and do this. This is how we thought telemedicine would progress at that point of time, but suddenly with the COVID coming in, we realized that there's been a dramatic change of how we practice the telemedicine. So during COVID, as I told you earlier, we actually set up a separate telemedicine platform where we could do all these activities for seamless consultation and also for specific scheduling across specialties. As telemedicine became very popular, there was a lot of streaming coming into telemedicine. We had to have a separate setup and a separate group of people who are managing this in terms of giving the right appointments and so on. So what has happened to teleconsultation after telemedicine? There has been of course a dramatic increase after the first wave, and also our new platform enabled us to scale up very quickly, because during the second wave, where there was a virtual and physical lockdown, everything was locked completely. At this point of time, it was telemedicine that actually helped us and helped the patients in transforming medicine into important science. And you can see that these are the average telemedicine consultations per day per month that we are doing, and you can see that in January 20 it's extremely low, but as we go up by June, August of last year, and now April of this year, we are actually peaking and doing almost 600 at a time. You can see these high peaks that are coming. The second component, third component of telemedicine that we used is education. Education for community and education for doctors. For community, we reached out to the public with educational contents on relevant health issues. In fact, since 2020, we have had 150 such educational programs for the community where we could transmit health information, simple information not only related to COVID, but also general health, how to keep fit, how to keep healthy, how to keep your heart healthy or liver healthy, and so on. All these programs are conducted at extremely regular basis, almost 2 to 3 per week. Of course, there were other concerns, for example, psychological issues that were there, which the lay people had to know. All this came into public health talks that we started giving, and this became extremely popular. Over 14,000 subscribers were there for this, and of course, I'm sure it multiplied in other venues also. So through our public health talks, we covered over 20 specialties, all were covered. The other important thing what we did was in telemedicine was doctors education, and this became extremely important because normally doctors would have physical meetings almost every week to gather together to see what is latest in science in that area, and of course discuss, and this would benefit the doctors a lot. So when this lockdown came, I think we have immensely handicapped by this, but fortunately with telemedicine we could overcome this. We started several series of talks, initially on COVID because that was important for us to concentrate on. We would invite doctors from all over the world to come and talk to us because our experience was very initial, and later on it went to other specialties. 300 scientific webinars were conducted during this period, featuring over 10 countries and almost 30 to 40 experts coming in from different countries. So it was a huge effort, and is again very important to emphasize that if this was done in a physical way, it would not have been possible, not only because of the economics involved, but also because of the time span traveling from country to country. What we realized was that with this telemedicine, not only could we get the best speakers at the best time and very frequent. This is a very important thing. For example, From the COVID thing, we also now went into other specialties. This was an extremely popular seminar we did, for example, for detection of early cancers. We took the expertise from Japan for this early GI cancers, and speakers like Norio Ueda, for example, were there to tell us, guide us how to detect these early cancers and how to, it was as if it was a physical meeting, because there were excellent videos and so on, because of improvement of telemedicine platform. And eventually, I think we could get a huge experience from this. And I think this is one of the benefits of COVID. In fact, one of the positive features of COVID was developing platforms like this for tele-education of the doctors. We also had several postgraduate programs, for example, approach to GI bleed, focus courses for medical students were conducted throughout, and I think they benefited immensely. Now, all the medical colleges in our state, for example, are connected with this, and anybody can view any program going on. Can you imagine the huge amount of expertise that is available to these students now? So, we connected to experts from across the world, and this is just to show you how we were extremely fortunate to get some of the top experts. When we started initially, because this COVID started in China, we got the top expert from China, Dr. Ran, to talk to us how they were managing COVID. Then Spain became a center, and we had Dr. Chen talking to us. And then we went over to Italy, where Dr. Repici, huge experience in this area, talked to us. And then from there to Belgium, again, Professor Guido had a huge experience with vaccines. He talked to us about future vaccines. And then right across to the east, Hong Kong, Tuing was again another prominent GI specialist who gave us a talk on what to do during this period. And of course, in Germany, Torsten Bayana, again at that time Germany was starting to experience an increased urge, and then we came to the United States, where we had Dr. Amrita Seth talking to us. We had talks coming in from Israel, because again Israel was very successful in actually stopping this trend with vaccination. So, we had in Israel how they overcome with the innovations, and so you see this was a very, very rich experience, and this traveled from country to country, and all we had to do was sit in our studio here to watch. These studios have become now extremely important component of the hospital. So, going forward, what do we expect and what is going to happen? I think some medical specialties, like for example dermatology or behavioral sciences or psychiatry, are going to become more and more involved, and virtual specialties are going to become the main component of this. Hybrid telemedicine is going to be an important component, where you have both patients telling us, sending us things, and then of course, I will go further to how they can actually send you the data better. Patient data security is going to be important. I think this is the area where we are still emerging. Some of the countries like US, for example, are very strong with HIPAA compliance and so on. But we have to now get good patient data security, because if you want to exchange, if you want to network, if all the hospitals in this country are going to be connected with patient data, then you have to have patient data security. And most importantly, in our country, I think what is going to happen is that primary care at remote places, for example, in Northeast, in hilly areas, in remote tribal areas where we don't have access to, telemedicine is going to become a very, very important way of treating these patients, creating a hub and spoke model where patients with more serious diseases here can be brought back to higher centers, but others can be treated there itself in their place. This is going to be an extremely important component of how telemedicine is practiced. So, we are going to have several devices, and already there is a lot of research. I know a lot of startups which are coming up. I am part of a enterprises along with IIT's Hyderabad, where they are coming up with many, many new devices. For example, external camera with thermometer and otoscope can be put in, and the pictures can be actually transmitted to the ENT surgeon, so you don't have to be physically there. Similarly, a stethoscope with adapted to heart and lung sounds, a stethoscope which can magnify the heart sounds, so that you don't have to again auscultate the patient, and for a tongue depressor to look at the throat, and so many new things are going to come in, and all of these are going to make it much more easier, much more scientific, and much more reliable to practice telemedicine. And I think this is the way we are going to go forward. You can see there are some very, very exciting changes that are coming in. I think this is now the time for us to act together along with doctors, engineers, AV, everybody coming together to adapt these technologies and to take them forward, both in terms of patient care, medical education, and so on. I think we are in a very exciting times in this era, and telemedicine has now become very stabilized as a part of our daily life. Once again, I think it's very important to realize that the developments that are going on, especially integrated patient-friendly technology and software, it is going to become much more easier for us to start using this in future. I'd like to thank TEMDEC, and I think they have been the ones who have actually propagated this much before the era of COVID, and now how prophetic this has been, because we're going to use it very commonly now. Thank you very much for your kind attention.
Thank you, Dr. Reddy, for an excellent talk on telemedicine experiences during COVID-19 pandemic. So if there are any comments from anyone or questions, so then if there are no more comments or this thing, we can move to the next speaker, Dr. Kalaiarasan Raja, who is an associated professor of surgical gastroenterology at JIPMER Pondicherry, and he is graduated from JIPMER, and then he did his master's from JIPMER again, and then he did his MCH from GB Pant Hospital. He has more than 40 publications to his credit, and he is a member of many associations, and he's also editorial board member of Journal of Gastroenterology and Hepatobiliary Research. And may I ask now Dr. Kalaiarasan Raja to deliver his talk. Kalai, are you there, Kalai?
Thank you, sir. Thank you for the kind introduction. At the outset, I'd like to thank the organizing committee of the AIG and the TEMDEC for this wonderful opportunity. So I'll be speaking on the feasibility and effectiveness of video teleconsultation for patients requiring super specialty care, the experience we had during the COVID-19 pandemic. So for the international viewers, so the JIPMER is located in Puducherry, which is a small town in the southern part of India, and has multiple tourist attractions. So the overview of my talk would be the teleconsultation platform which we used during the pandemic, and also the feasibility and effectiveness in the medical and surgical super specialty. So as highlighted by the previous speakers, so while COVID-19 had put a significant challenge on the healthcare, in primarily by limiting the physical visits and the conventional medical care delivery because of the frequent lockdowns and the less number of healthcare workers who are available for delivery at a particular time, as even the healthcare workers were significantly affected by this pandemic. But the benefit we gained out of it is it provided us an ideal platform to explore the telepatient care. So in JIPMER, we were doing teleconsultation, but roughly the teleconsultations used to be in single digits in a particular department. But that has significantly changed after the COVID-19 pandemic. And over the next 10 minutes, I'll be just sharing our experience and some of the limitations we face. So the video teleconsultation platform, which was developed during the pandemic time, was a custom-made application made by the hospital information system provider. Some of the features are it will utilize a very minimal bandwidth, even for the video consultation, and also to ensure the privacy and the security of the channel which is used for video consultation. the link which will be shared to the patient to initiate video consultation will become active once the consultation is completed. And that's to prevent any misuse. And also the link will be initiated by the physician rather from the patient end. So since we created the teleconsultation platform, so we realized for the patients to fix an appointment, we need a very simple method, and that's why we created an app which can be downloaded from the Play Store. So this is a very simple app which will display the various specialities which provide teleconsultation, and also the contact details and the complaints which can be tackled using teleconsultation. So this is the app which was created. So using this app, patient can go through, see which specialty they need to contact for their complaints, and they can directly make a call. So this call will be received. So in addition to the app, we also, what we did was we created a separate the website during the COVID-19 JIPMER. And this has a link for downloading the app, and also patients can, if someone, an educated patient, they can actually directly book an appointment instead of making a telephone call. But predominantly, as JIPMER is a government-funded hospital, it predominantly caters to patients from a lower socio-economic status. So the platform which we create need to be very simple, that can be understood by a patient with a very minimal education. So that's why we created these simple apps. So once they make a call, so this is actually supposed to be our MRD, that is a medical record department, where in a normal scenario, we will have physical registration happening. So during the peak pandemic, when the outpatient clinics were closed, so we converted this to a call center. And so the calls are received by them, and they make a booking. So what they do is they use this, this is our tele consultation platform. So they make an appointment based on, first they actually create a hospital number, they make an appointment depending upon the complaints. So this is how the appointment booking is done. Now, once the appointment booking is done, then actually the confirmation of the appointment is done by the physician. Now the physician has two options. As a protocol, he actually makes a teleconsultation. That's the first thing. So if the physician feels that the treatment cannot be initiated based on teleconsultation, then the patient will be called to the hospital. So this is how they do it. They first confirm the appointment, then they make a call, and depending upon the complaint, either they can ask the patient to come to OPD, or they can finish the consultation over teleconsultation itself, or it can be asked to come to the emergency. So these are the various scenarios we will have, and so this is how the teleconsultation was done during that period. Now, so this is one of the specialities where the telemedicine follow-up has been performed. So I will share the second component of my talk about the feasibility and the effectiveness based on the data which we have published. So this is basically primarily the publication, and then we have another publication which is in process. So for the purpose of talk, what I decided was I'll take one medical specialty and a surgical specialty and what was the experience. So now this is in a medical specialty. These are the patients who have epilepsy. Now, the patients were selected. The two criteria, which for the inclusion in this study. One is the patients have called and requested for consultation. That's the first group. The second group are the patients who have been previously seen by us, and then they're supposed to come for a follow-up visit, but they could not come due to the lockdown. So 336 patients were randomly selected and planned for a video teleconsultation. In that, actually 195 patients we could not initiate. And now this highlights the problem, because the success of teleconsultation varies depending upon the hospital setting, the type of patients you are catering to, and also amount of prior training. Because when we do a routine consultation before the pandemic, so the patient would have come for physical visit, and usually we actually teach them how to connect for this video teleconsultation in their future follow-ups. Now, this was initiated during the pandemic, where a significant number of patients did not have the prior experience of this video teleconsultation. So in 190 patients, we could not initiate the consultation. Of the remaining 141 patients where we could contact them, the video teleconsultation was successfully completed in 95, and another 46 we ended with just audio teleconsultation. So this is just to give an overview in a setting where the patients are primarily from lower socioeconomic status, and this just gives an overview of the feasibility of the telemedicine in that setup. If you see the reasons for failure to initiate video consultations, so predominantly it is like an absence of smartphone. The patient don't have the smartphone, and then despite using an app which utilizes a low bandwidth, still network and connectivity issues, and we're not in a position to pick up the call. So these are predominantly the reasons why we could not initiate video consultation in those 150 odd patients. Now, when we come to the effectiveness of telemedicine, so what we did, of the 95 patients in whom the teleconsultation was successful, so we asked them, these are the questions which were asked, and so as you can see, could you easily talk to, so I'm not really going to read about each of these questionnaires, but it's roughly around 12 questionnaires. And then if you see in patients in whom we have successfully completed, their satisfaction levels is pretty high, more than 90% in most of the questions we have asked. So one thing which I need to highlight here is, do you need assistance while using the system? So if you can see, is roughly 50% of the patients actually required assistance by someone in the family or by the neighbors to complete the video teleconsultation. And that's about the medical, and this is the surgical patients. This is the patients in our department, the GI surgery. So if you see, the 62% of the patients rated it as good, and 22% rated average, and 15% of patients were not satisfied. If you see the satisfaction percentage is slightly more in the medical specialty compared to the surgical specialty. So these are the other activities which were done during the pandemic. This is like even within the hospital to minimize the patient-physician interaction. So we use this simple innovations of having a tele interaction of the patients who are admitted in the ICU, so you don't have to frequently visit. And also even the patient relatives, since they could not visit the patients, so we had this type of simple tabs which were kept one inside and one outside, and they can have the interaction. And also even the rounds, the ward rounds, the number of doctors attending the ward rounds can also be minimized by having this type of doing a virtual ward rounds. So to conclude, the telemedicine is feasible and effective in selected patients requiring super specialty care, and I need to highlight this. Patient selection has to be dependent upon the various the medical and surgical specialty, and also the type of patients the hospital cater to. That's very important to ensure the feasibility and the effectiveness. And we need to keep continuously innovate, and the innovations should be focused on addressing the patient demands so that we could further improve the satisfaction with this video teleconsultation. With this, once again, I thank you for the opportunity, and I'll be happy to answer any questions.
Thank you, Kalai, for an excellent talk and sharing your experience of teleconsultations. Any comments or any questions addressed to Dr. Kalarasan? Any of the Okay, we'll move to the next speaker, Professor S.K. Mishra. Professor S.K. Mishra is a pioneer in telemedicine, and he is single-handedly responsible for setting up of telemedicine department in SGPGI, Lucknow. And Dr. Mishra did his general surgery from PGIM, Chandigarh, and after the brief stint as a faculty, he moved to SGPGMS, Lucknow, as to establish a department of endocrine surgery. And Dr. Mishra has developed a passion towards ICT in healthcare, and education has been involved in application-oriented telemedicine research and development and deployment projects for over the last 2 decades. He was consultant for ITU, WHO, and UN in e-health. He is the founder of School of Telemedicine and Biomedical Informatics, which has been designated as a National Resource Center by Ministry of Electronics and IT and Ministry of Health and Family Welfare, Government of India. He has been selected as WHO roster of experts for digital health. So, Mishra?
Yeah, thank you, Pradeep. Can you hear me?
Yeah, we can hear you, Mishra.
Yeah, so there is some little communication gap, so my PowerPoints I could not organize, but I can send it after the meeting. Today sometime we can put it in the portal. So I'll be giving an extempore talk about what we have done actually, in particularly in COVID times, and also what are the state programs and national programs you are involved. People who are in this group in previous consecutive years, this event organized by Dr. Simiju, they know about our activities. We have been presenting every year. And this time, the new things that have come up, what you have already said, our work in Lucknow, in Uttar Pradesh, is the COVID time priorities for the institute as well as for the state. So I'll highlight those points. One is the electronic COVID care system that we introduced during COVID time. In that, the whole state was divided into different zones, and from the primary level till to the top level of hospitals, we developed such hierarchical systems. So every care providers were connected to the different hierarchical level, and depending on the situation of the patient, the consultation can be achieved from the topmost hospital if required. So that is the thing that we have done it. That is one of the very remarkable things, and that has rarely made the management of COVID during the pandemic. Still, it is continuing, and we are still in readiness. Our tele-OPDs are still running, and our emergency care for COVID calls are still running. But you do not know if the third phase comes, then we'll definitely carry on. So the next point that we have done is the entire educational system that has been transformed during COVID times, like many other institutions also. All our classes for undergraduate, postgraduate, everything are being run on the online mode. We reuse the different kinds of software or video conferencing, not only in one software. So there any problem with one particular software also, we can manage with other alternatives. So it is an enterprise system that is not only in the institute, also outside institute we are connected. Second point is regarding the situation of examination, governance, etc., teaching programs, etc. For that also, we have all our exams online, and we have made the entire exit exams online, and all the external examiners are also put on video conferencing. And we could manage the entire 2 years, last year as well as this year, through online mode. Of course, it was approved by our regulatory body, so we could manage it. The fourth thing that we have done is a very remarkable thing, is setting up a tele-ICU. So the tele-ICU was started in a very ad hoc manner, just connecting video and collecting the doctors there, sitting there and taking the information on a case-to-case basis. But now we are setting up a tele-ICU in a very highly technical manner, where as a sample pilot study, we are connecting 6 medical colleges of the state. Later on, we'll connect all 52 medical colleges of the state. So this tele-ICU also is going to make a lot of change in the future critical situation like pandemic this time. So all these things, let me tell you, it has all happened because of the COVID. And all of us, all healthcare providers, all institutions, all the government have realized that we need to have a strengthening the infrastructure. So that's the message I want to give today in this meeting, that institutions like ours should take the lead to advise the state government or central government how we should really steer our healthcare system so that the future such critical situation also can be taken care of. And at the same time, let me emphasize also, why should we wait for a pandemic to come? We should be there all the time, because critical care, connecting the ICU, can occur anytime. It's not only during pandemic. Day in and day out, you require critical care support. We do not have peripheral support systems, but all our district hospitals, all our medical colleges, not all equipped in terms of the human resources expertise. So that we can provide through this 24/7 telecare services. So that's one message I want to give, that we are preparing ourselves, and government is also giving budget on this head to strengthen the healthcare systems or health infrastructure systems in different level of the hospital. So that is a very remarkable thing that we have seen across the country, and whether it is a corporate, whether it is an academic institution, or it is even a medical college in periphery, or a district hospital in public health systems. So that has really happened, and we do not want to give a credit to the COVID, but COVID has really made all of us to completely transform at the individual level, at the state level, national level, global level also. The point that I want to highlight is institutions who are already practicing telemedicine. Again, that point I'll highlight, they have helped, because in India, many institutions in previous this symposium, I think Dr. Symposium knows very well, India is in a very, very state of advanced preparedness for telemedicine many years ago. And we could really kickstart with the pandemic coming up. We really helped each other to build a telemedicine system, and proper telemedicine system. Of course, during COVID time, everybody used telemedicine the way they liked it. I always say that it is a kind of 8 blind men catching up an elephant and identifying different body parts. It is just like that. Anybody is doing a video call or WhatsApp video, thinks that this is the telemedicine. Anyway, the basic purpose is to reach out to the care providers. So that we could do it in different kinds of media that we have. Very specifically, I must say that the educational systems need a lot of transformation in terms of regulatory bodies' approval for accepting this online mode. Why it should be only COVID times? So why it will be in critical times of in this disjuncture? It has to be part and parcel of day-to-day learning. We just completed a conference, an international level telemedicine conference in Lucknow, where we have really emphasized how e-learning should be part of our medical education system to just complement our existing medical education system. But the entire course content, everything can be better delivered rather than allowing the people to imagine certain things. This all can be linked, interlinked. Our system has to be interlinked. The teachers and the students and the knowledge resources has to be interlinked. One thing I am already in touch with Dr. Pradhuri Bella, and he was also one of the chair in the current e-learning session symposium, that we need to develop a lot of contents, lot of educational content. Day in and day out, we are making a lot of case contents. We are teaching the bedside. Capture those contents and keep it. And I must appreciate the AIG's initiative for their online educational system for the DNB students. And that is all can be of help to the national level if they can capture the content and allow us to keep in the national repository so that your content can be accessed to many other students. So some messages I have just given out of our experience, and all of you know about us, and so I don't want to repeat. In any case, I'll be sending on slide set, so you can keep it in the portal for future reference. Any particular questions comes, I can take it up. Thank you.
Thank you, Dr. Mishra, for innovations and the advances you have developed for telemedicine in India. Any comments or questions from the audience? Dr. Yeah.
Yes,
Go ahead.
I have one question. I think we had Dr. Mishra talking about tele-ICU. How effective it is going to be in future, sir? Tele-ICU, the concept is very good, but at the same time, if you see patient perspective, they may not be very happy unless and until they see the doctor physically there, and they want the doctor to touch the patient and talk to him personally. How effective it is going to be in future, sir? Tele-ICU concept.
Dr. Satya, let me tell you, during COVID times, is the patient ever bothered the doctors to touch? They just want to talk to some doctor, not even ICU specialist. Is that exactly I'm telling you? The entire healthcare system at individual and institutional level has to be transformed. And let me tell you, COVID has made patient to realize there is no need of doctor to touch the hand. It's very important just to believe the system. So we have to make our system that kind of preparedness. For example, if you talk of AIG, somebody wants to refer to AIG, patient goes blindly. They don't know who is Dr. Pradeep, who is Dr. Satya, anybody else. They know the reputation of the institute. So we have to make our health system that kind of resilient, where each and everybody realizes that if I'm in the system, I'll be taken care of. Right? So now coming to specific to tele-ICU. Tele-ICU is important in the sense that the patient in the peripheral hospital, you just imagine that you are not in the AIG, or you are not in Apollo, or you are not in Medanta. Just imagine the patient is in somewhere in the periphery, in the district hospital or somewhere. How you can manage really the patient there where there is no expertise at all. So in that situation, so we have to understand. Hello?
Yeah, you can hear you. We can hear you.
Yeah, so there's some discharge of my devices. So in the district hospital, just imagine there is no ICU experts. Even in medical colleges, you know, when we did the survey for the deployment of UP Medical College network for ICU, we found there is no even critical care expert, not in a single medical colleges. Only the anesthesists manage these things. Okay, they are also managing the ventilator, but what about the entire critical care setup? So in that sense, what we have to understand is we have to develop a system where the patient data is getting seen by somebody in the higher level and advice is coming there. Now, of course, they will see the doctor. They cannot feel the doctor. That is fine. Many of the critical care patients are on ventilator. They are in unconscious state. They don't know actually who is the doctor where. Only the relatives has to put in the counseling and they can understand these things. So tele-ICU is coming up. It's already in the many of the corporate hospitals in India. They are practicing it. Let us see how it goes in a public health system. Hello.
Yeah, thank you, sir. Thank you.
Thank you, Mishra. Any other comments or questions from the participants? If there are no comments, so we'll come to the end of this session and thank all the speakers, Professor Reddy, Professor Sarat Mishra, and Professor Kalarasan Raja for an excellent panel discussion on this topic of telemedicine.
Thank you.
Delivery. Thank you. Hand over to Dr. Mr. Satya.
Sir, thank you very much, sir. Thank you very much for conducting this session very well. And there are a lot of inputs from all the speakers, I believe. And next, we'll move on to the next session, that is keynote lecture. And I request Dr. Uday Koirala and Dr. Mr. Mohan to moderate this session. Mohan and Dr. Uday Koirala.
Good morning
A lot of these
to
questions
ATS
were answered by
2021.
article by Kotecha and which was published.
Dr. Uday, are you there? Okay, let us start. Now the move on to the section 2 keynote lecture. This is actually Asian Telemedicine Symposium for Past and Future, presented by Dr. Suji Shimuju. Before that, let me take the privilege of introducing Dr. Suji Shimuju. General Surgeon. He is Vice President of Asian Institute of International Affairs. He served Chairman and Professor of the Department of Internal Medicine Department, as well as the Director of the Telemedicine Development Center of Asia. He is also worked as a Chairman and Medical Working Group of APAN. Over to Dr. Suji Shimuju.
Okay, can you hear me?
Yes, sir.
Okay, thank you very much. So thank you for giving me this opportunity to talk about the Asian Telemedicine Symposium, past and future. So my talk today is mostly to review and look back what we have done so far during the 14 times of the symposiums. So as you see here, 6 of all were held in Fukuoka, Japan, Kyushu University, and the 3 in Korea, and the other 5 were organized in other countries in Asia. So I'd like to review one by one, except some some Japanese ones. Okay, so before looking back, I'd like to reconfirm what were the aims of ATS when we started in 2007. The first 2 were shown here. Like one is to review the activities of the current year, sharing good programs and sharing problems and troubleshooting. And the other is to talk about the plans for the next year by intensive discussion on site. But more importantly, I aimed to have the communication between doctors and the engineer, sharing needs and limits. And the 4th is for the local engineer, who usually almost always work just remotely. So I wanted to give them to meet in person at least once a year. So those are the aims when we first started this symposium. And this is a flyer of the first ATS in Kyushu University. But the one I myself was surprised at was at that time the Temdec did not exist. We worked under the name of Aqua as a volunteering staff in the hospital. So the Temdec was founded the next year in 2008. So that was, surprising to myself when I look back. And the reason why we started this symposium in 2007 was that we won a small fund to organize an international meeting. So I just thought the telemedicine symposium to be quite nice around that time. So this picture shows the main venue and the 3 important persons. One is the vice president of the Kyushu University, and another is an officer from the Ministry of Education, and the 3rd is the director of the Kyushu University Hospital, because this symposium was quite a formal one. And we had a simultaneous translation because we invited many Japanese audience, and we did a teleconference, which was not so common around that time, by connecting Japan, Korea, Singapore, and Australia. And this is a group photo in front of the menu. And in this first symposium, we invited 150 participants from 8 countries and regions. And, Taiwan, Malaysia, Hong Kong, Thai, Philippines, Korea, Indonesia. And I looked for the one from India, who is Manoj from Tata Memorial Hospital, but somehow he was not in this particular picture, although he made a presentation and he joined our first symposium. And we cannot forget that there are two strong supporters, Johnson & Johnson and Olympus, from the very first symposium we had many years ago. And it's quite a sad fact that Dr. Salim Ali Sangha in Indonesia, University of Indonesia, passed away recently. And this is the second symposium held in Bundan Hospital, Seoul National University. And Dr. Ho So-han was the organizer. He's a good friend of mine, surgeon. And he also had a strong interest in telemedicine around that time. So actually, he and I, thought about this kind of symposium at the very beginning. And this is just a group photo, and a little bit too small to recognize each person, but it was a good memory to have a first symposium in Korea. And 2 years later, I skipped one Japanese one, the third one, but Dr. Junso Han was the organizer. And he did this in a Hainan University Hospital. And actually, the Hainan University Hospital was the very first university which was connected by a big research and education network with a very big bandwidth around that time. And Dr. Junso Han was the team. I mean, he and I worked in the very same lab in the United States several years before. And when after both of us came back from United States, we talked about the good possibility of telemedicine, and his own university happened to have been connected with a big network. So that's why we could start a collaboration with him and his university. And skip another Japanese symposium, but this is a sixth ADS held in Kyushu University in 2012. And Kyushu University started the telemedicine activity itself in 2002 when Korea and Japan had a World Cup, soccer game. So this 2012 sixth ADS was held 10 years after we started the telemedicine activity between the two countries. So this was a quite commemorative meeting. Sorry. And then the topic we made was what's the direction for the next 10 years for the telemedicine. And this was a group photo, and we did it in a big auditorium, and 110 local and 11 remote participants from 18 countries in this 10th Memorial Symposium. And you can see some familiar faces. Dr. Hilbano also passed away several years ago. He was a good surgeon and a telemedicine leader in the Philippines. And Paul Naron was, head of the Thai telemedicine activity. And, we started the collaboration with Europe around that time, and Mr. Jerry, engineer, traveled all the way to Kyushu University around that time. And also we invited Luis from Brazil, from the opposite side of the earth, for the first time in this particular memorial symposium. And the seventh was another memorial symposium, because it was the first time that we organized this symposium outside Korea and Japan, in Thailand. Dr. Tawachai in Syria Hospital and Dr. Ronson in Chulalongkorn Hospital co-organized this symposium. And of course, lots of people all joined and traveled to Bangkok. And this was a group photo in the yard of the university campus, hospital campus. And of course, we had lots of presentations and a hospital tour to the endoscopy room on the left bottom, and the medical museum on the right bottom. But actually, the highlight of this the Thai symposium was a night cruise. This was really, really unforgettable memory because they had a big yacht only for participants. And we had a big party there with the music and the bands and something like that. And all the people enjoy not only the buffet, but also song and dance and something like that. We owe them very much in this particular meeting. And the 8th meeting again in Kyushu University, around that time, we started collaboration with the National University Hospital in my own country. What we found was that we are getting more and more active with the international telemedicine activities, but not so much domestically. So that's why we put the topics as the international expansion and domestic expansion, because I wanted to expand this activity inside the country, not only in Japan, but also other countries like Indonesia, Philippines, or India, or whatever. So that's why we put the slogan like that. And this is again the snapshot, group photo, and venue, and something like that. But another highlight is the night, gathering. You can see the Antok-san in the center top, and he was a really entertainer. So everybody laughed, looking at him. And Saroj, Dr. Saroj from Nepal, and Minton Lin, surgeon from both surgeon from Nepal and Taiwan, visited us, and also we invited the engineer Harold from Mexico all the way from American continent, and we had a very good night as well as a daytime workshop. And the 8th, again, was held in Korea, and Yanson Lee was the organizer at the time in Chumbuk University outside Seoul for the first time. And again, we had lots and lots of people gathering. And because he's a specialist of the health, public health, the slogan he put was Asian Telemedicine for Public Health Crisis. And the venue was seen like this, and they put big flower decoration in front of the entrance. And somehow, what I remember well is that probably the Jeffrey from the Philippines and Sheila Johnson, Dr. Sheila John from India, should have joined us for the first time in this particular meeting in Korea. Sorry if I remember wrong, but I do remember meeting you here in Chumbuk. And also I remember that there are several Philippine people join us for the first time, and some from Indonesia as well. And this is a group photo, and also the remote participant on the screen. And then the 10th symposium held the first time in Vietnam, in Vietnam Hospital. And Dr. Jian, another surgeon, hosted this symposium. And his theme was telemedicine in developing countries. And this is a snapshot and a good memory again. And in this particular meeting, they held this telemedicine symposium together with the big surgical meeting. So that's why the venue was really full of participants, and many, many people enjoyed our presentation. And this is another snapshot. And, many of them are surgeons in Vietnam, and, something like that, and lots of people. And Dr. Akiyama from Japan used to work in Vietnam for years, so that's why we invited him as a speaker, and we enjoyed his talk as well. And the 11th, we went to Malaysia, and Dr. Ho, physician, became organizer. And his theme was application of educational telemedicine in teaching hospital. And the group photo, a big screen, and you can see the very familiar faces again in this picture. And the 12th, in 2018, we came back to Fukuoka, and the particular thing here is that we co-organized this ATS with the 22nd Japanese Telemedicine Congress, and the 45 presentation by 19 countries and regions, and 600 participants in total. And I really wanted Professor Moriyama to be an organizer here. So he made a good program together with the Kuriko as a program committee. And the topic he made is telemedicine expanding to the world. And this is a snapshot, committee meeting on the right bottom. And should have had the two venues here again. And this is the group photo here in 12th meeting. And we at that time had participants from Nigeria in Africa, and the Chile from Latin America, and the Kyrgyzstan in Central Asia, and of course Bangladesh. Big people from Bangladesh. And the 13th, 2019, we went to the Philippines, and Jeffrey Domino and Catherine Tay co-organized the meeting. It was another really good meeting. And the topic they made was practical application in telehealth, expanding access to telehealth in surgery. And this is a snapshot, and good ones, and funny ones as well. And they invited Dr. Yankap from the International Society of the Telemedicine and e-health, and also the doctor from Japan, Japanese doctor, who presented virtual reality and something like that. And then the next year, the COVID-19 prevailed the world, and then a situation changed a lot. The organizer was Dr. Chen and Qian-san in Taiwan, and this was the first time they organized the ATS online, virtually, so except the Taiwanese participants. So that we made teleconference, which was good for us, not so difficult at all. So this was a special year for the telemedicine ATS. And looking back, all these 14 times of ATS, I think that now we would be able to say that we entered into the age of the telemedicine 2.0, because when we started the telemedicine activity 20 years ago, to connect the hospital with a high quality was quite difficult, and it was one of our aims in telemedicine activity. So if we can get the connection, and we can invite the new people, and could have been able to connect to the new hospital, that was our another achievement. But now, after with the corona pandemic, the telemedicine situation should be changed a lot, as you are aware. So now the new systems like Zoom and Teams are available, and the commercial networks work well. In contrast with the time we use the big bandwidths of the academic network, or we use the DBTS with the 30 megabps. and the remote work and online meetings are now known in the society. So today we are having a 15th ATS under the title of the Telemedicine in Post-COVID Era with the leadership of Dr. Reddy and Mr. Satya. And I'm very happy to have another chance of joining the ATS and looking forward to another variety of the good presentations. So, but I believe that we need the new types of discussion compared with the last 10, 20 years. And also, I sincerely hope that the telemedicine will continue and grow for years ahead. Thank you very much.
Thank you very much, sir. I think Dr. Uday, are you there?
Thank you, Professor. Very nice. You also had a track of this ATS past. Thank you, Professor Shimizu, for this effort that you have been making to develop telemedicine. Next, our keynote lecturer is Dr. G.V. Rao. He is the director of the prestigious Asian Institute of Gastroenterology, Hyderabad, India. Which is also a part of APAN. Dr. G.V. Rao, he is Chief of Surgical Gastroenterology, Minimal Invasive Surgery and Transplantation Services. So, Dr. G.V. Rao.
Good morning. At the outset, let me thank the entire executive of the TEMDEC and Professor Morishima for the honor bestowed and asking me to talk on this topic of artificial medicine in telemedicine. Now, the entire concept of patient care, right from the time it started centuries back, is all about the natural intelligence of the clinician, plus a lot of empathy that is involved in treating these patients. And this patient basically involves clinical examination, investigations, interpretation, treatment planning, execution, follow-up of these patients, some amount of research, training of clinicians, and of course, we talk about the burnout of physicians. Now, this is what is called as on-site medicine, which is combined with empathy and natural intelligence. So we have natural intelligence, which is combined with empathy and on-site medicine. Now, telemedicine, basically, it's a concept of exchange of medical information from one location to another using electronic communication. It's become an integral part of healthcare, penetrating public hospitals, private clinics, and even people's residences and workplaces. Healthcare delivery organizations are on the threshold of a seismic change in clinical care delivery and seem to recognize the value of virtual care and telemedicine in clinical practice. We're talking about e-health today, and as per the latest definition, e-health is an emerging field in the intersection of medical informatics, public health, and business, referring to health services and information delivered or enhanced through internet and related technologies. Broadly, it's not only technological development, but also state of mind, a way of thinking, an attitude to improve healthcare locally, regionally, and worldwide by using information and communication technology. We have 10 different ways that the hospitals are going to function today and tomorrow. Looks like the hospitals will be smaller and more specialized. Looks like the hospitals will be more user-friendly. The staff members will be reduced. Telemedicine will be everywhere. Robotics will play an important role. They could be improved in non-invasive monitoring. ICUs, as initially said, could be monitored remotely. The patients likely to be mobilized earlier, and there will be continuity between the hospital and home care, and ethical decisions will be openly discussed, and end-of-life care could likely to be improved. These are the 10 things that are going to change the hospital or the clinical care of tomorrow. Now, artificial intelligence is an ability of computer to perform tasks and cognitive functions like human beings. This is what is called as artificial intelligence. And use of artificial intelligence in telemedicine will play a massive role in bringing about this seismic change in healthcare. AI and telemedicine can work as a perfect partners in providing better healthcare services. Telemedicine has already incorporated use of technology in the form of wireless tools, smartphones, and other telecommunication devices. Now, integrating AI in these tools will be relatively easy, and this will further enhance the usability of these currently available devices. And we're talking about the mHealth, the mobile health as in today, wherein monitoring health is done by using mobile phones and patient monitoring devices. And this seems to be a substantial breakthrough technology in the modern era. And AI in telemedicine seems to be the most happening, most curious, most invested, and most rapidly expanding emerging specialty in clinical medicine. And if you see, there's a lot of literature to show that the smartphone-based mHealth model with artificial intelligence and big data analytics for providing an effective healthcare system seems to be the next generation healthcare that is going to be witnessed in future. If you look at the number of publications of artificial intelligence in telemedicine, you see the number of publications coming from across the globe. And in fact, India seems to be one of those countries which is leading in these publications with artificial intelligence and telemedicine, basically because of the heavy support from the IT industry. Now, what are the benefits of artificial intelligence in telemedicine? There are several advantages. It seems to providing better diagnosis. Remote diagnosis is possible due to telemedicine. Doctors can monitor, diagnose, and treat diseases remotely and helps reducing patient visits. A considerable amount of time and labor will be saved in screening process. And with ease of diagnosis by using artificial intelligence, doctors and patients can expect diagnosis to become time and cost-effective process as compared to the existing procedures. It also can start recommending treatments. The AI algorithms can analyze the past medical records and provide treatment options and solutions to the patients. And it significantly reduces the time spent by doctors in going to the medical history and in prescribing or recommending the best suited treatment options. It also seems to be preventing physician burnout. As in today, the long working hours and days seem to be leading to increased stress, frustration, and burnouts, and also seem to affect the work practices of clinicians. Prolonged interactions with patients and spending substantial amount of time on electronic devices seem to be causing burnout among physicians. Telemedicine seems to be helping medical professionals cope with burnouts, and combined with AI, the benefits seem to be multiplied. And AI can help reduce physicians' digital screening time, help identify signals that indicate symptoms of burnout, and even can predict how many patients a doctor can see before a burnout syndrome. And it seems to be helping in providing better healthcare to elderly. Telemedicine is associated with mobile devices, and in future, assistive robots will play a huge role in providing healthcare at the residents, especially for the elderly citizens. Now, these smart robots, as we call them, can perform tasks assisting people walk and move around the house, providing timely medications and alerting authorities in case of emergencies. They can understand the environment, behavioral movement patterns of the patient, can thus train itself to provide better support and work as a caretaker, have the potential to decrease the cost of delivering the healthcare services, and also improve the quality of life as they're available round the clock for assistance. They also seem to be simplifying the hospital visits. It promises to reduce the hospital visits, can help reduce waiting time during hospital visits. AI updates the staff members 24/7 about the patient influx, high priority cases, and need for additional beds and other information regarding patient care. The ambulance services efficiency can be tremendously increased with this information, and emergency room allocation of beds can be faster due to predictive analysis that we have even before the patient arrives in the hospital. There seems to be a lot of use of this artificial intelligence in telemedicine, as talked about by the earlier speakers today. AI in telesurgery seem to be the next in thing in clinical medicine. We've heard about the first Lindbergh operation that happened in 2001, where surgeons sitting in New York operated patient in France, the first ever laparoscopy. was done using this telesurgery, telemedicine, and of course some amount of artificial intelligence. This is the famous Lindbergh operation. This has several implications and it seems to be getting into clinical practice. I'm sure it's going to get into clinical practice very soon. An extension of this seems to be the next thing that can happen, and the most happening specialty in surgery is surgery about space. With more and more people traveling in space, it is likely that any emergencies during surgery, space travel can be tackled in space itself. A beautiful science fiction movie that came some time back called Prometheus very effectively depicts how artificial intelligence and remotely controlled telesurgery can be used to operate on a patient who is in space. Phenomenal movie, which science fiction movie, which shows how the patient can be self-anesthetized, trained, understand, and robotic, which are controlled from Earth, make an incision, make sure that the entire process is complete. And the best part of the whole process is actually the entire pathology seems to be out, and how this patient gets out immediately after procedure with we're talking about fast enhanced recovery after surgery in current clinical practice. The next generation ICUs, as earlier depicted by the physicians who presented earlier, seem to be remotely controlled by clinicians across the globe, improving the overall efficiency and overall outcomes of these patients in critical phase. And you can see this big data revolution in healthcare seems to be saving billions of dollars. And this is a beautiful paper which showed that just in US, this sort of AI in telemedicine seems to have resulted in saving billions of dollars annually. Coming to the next part of telemedicine or AI in telemedicine, training. This is the famous painting of how anatomy was taught way back in 16th century by Nicholas Tull. This is a beautiful picture, and we have a beautiful present picture that has come very recently to show how this entire concept seems to be changed, and the concept about art of medicine in the era of artificial medicine. This is based on a painting by Rembrandt's painting as to how the entire clinical situation could change from this physical to AI-based or mobile-based apps to teach students in current day clinical practice. GI surgical training started using a lot of virtual simulators in clinical practice because of decreased number of patient volume, or because of the rapidly expanding technology that is coming into clinical practice to make sure that the young surgeons are trained in this. We at AIG for the first time have combined our efforts with the Indian Institute of Science and helped in developing this beautiful endoscopic simulator, which not only helps in doing endoscopy procedures, it has artificial intelligence incorporated into the thing, and not only helps telling the endoscopist what are the faults that he is doing at the procedure, but again, the pathology that is picked up during the process can also be interpreted by the AI that is incorporated into this system. It's a beautiful system that has come into practice. It is being used extensively now in various centers in India and abroad. This is one such system which talks about AI in simulators, and obviously this can be combined with telemedicine to train surgeons endoscopies across the globe. And this obviously gives an interpretation at the end of the procedure to see how efficiently these doctors are trained. We also have intuitive learning and mentoring devices like the endoscopic and the laparoscopic and the robotic simulators. And these laparoscopic and robotic simulators seem to give a comprehensive performance charts and also give expert-derived goals interpretation from experts across the globe. It is now possible that we get connected with these devices to people across the globe to help improve surgical training and also get improve our own technical efficiency. So AI in surgical training, the implementation of AI to analyze and improve individual surgical training is likely to increase in coming decade with the introduction of AI in telemedicine. And as these technologies are unveiled, the training of medical students and surgical residents in machine learning techniques and big data analytics is essential to understanding of future research and endeavors in training program. So as I told you, AI-based telementoring in medicine seems to be an emerging technology where it's a real-time extension of providing surgical clinical devices and allows younger surgeons to train in a safety net and builds confidence at low cost, and it has benefits. The benefits are potentially enormous in current clinical practice. There are several innovations that are done at AIG Hospital. It is one of our innovations from our own junior consultants, was during the COVID time, made a laparoscopic simulator with the help of currently available, locally available material. And you can see this is a beautiful model that shows the use of artificial intelligence and smartphone devices. So at the end of the thing, what he has done is a lot of work has gone to this. And you can see a smartphone is used as a camera and also to record and also to analyze the entire performance of these simulation exercises that are done. These I feel are going to be very, very important, and these were connected to people across the globe can have excellent interpretation and also criticism from different parts of the world. So there are several ethical issues. The collecting large amounts of data could have privacy issues, data management issues, bias and fairness, and informed consent could be a big thing in clinical practice. So the concerns are, will hospitals, government, and even individual physicians purchase or license the use of these algorithms that are used in artificial intelligence? And legally, who would take the responsibility for the patients that are incorrectly diagnosed for cancer or that is missed during this entire process? To overcome this, blockchain and artificial technology seem to be the in thing, which is an open network for sharing and authorization of information. This could be the next in thing which could help in solving some of these concerns in artificial intelligence and telemedicine. To conclude, vast, rapidly growing tool in armamentarium of clinical practice, state-of-art machine learning algorithms are being applied to improve precision, safety, and automation. And we must carefully consider the ethico-legal ramifications of utilizing large patient data, the trust between patient and artificial systems, and mitigation of data breaches. Patient privacy, including patient records, genomics, and illness data, will need innovative solutions to ensure security. The assurance that data will be used responsibly will be of paramount importance in maintaining the patient trust in future years. And as digitization analytic techniques continue to improve, AI in telemedicine is poised to improve patient care and answer previously unsettled clinical questions, obviously improving the healthcare delivery. Future prospects hold much promise in enhancing patient outcomes, and experience will undoubtedly change the landscape of modern medicine. And as we embrace this groundbreaking technology, medicine is distinctly poised to make lasting impact contributions to clinical care and training. 76% of the US hospital healthcare system seem to be implementing this, helping in cutting costs, providing better healthcare, improving the work environment by reducing waiting time, suggesting best treatment options, and most importantly, to make healthcare available 24/7. So the availability of large amounts of complex data, advances in analytic techniques, and desire to maximize clinical quality and value allow us for a new era of AI-augmented evidence-based telemedicine practice, and looks like the era of artificial intelligence-based individualized telemedicine is going to be the next big thing in clinical practice. What are the competing technologies? Now we seem to be talking about augmenting natural intelligence. This is a fantastic science fiction movie which shows how the hardware can be inserted into the brain to increase the IQ of an individual. Initially, we thought it's a science fiction movie, and incorporating some amount of additional hardness into the brain seems to be a science fiction stuff. But this seems to be becoming a reality with memory enhancement trial, which seem to be moving into humans. I'm sure in the days to come, this will be a competing technology to artificial intelligence, wherein we are trying to improve the natural intelligence of the human. This is another science fiction movie which shows that instill some eye drops into the thing, and this gentleman should be able to see through the patient to see what is in. This again was thought to be a science fiction movie, but if you see what is happening, there is artificial intelligence coming into the human eye, which can avoid the smartphone's devices interface in between. It is likely that you get artificial intelligence incorporated into yourself, and this could avoid the smartphone device in between you and the patient care, and you can directly get connected to the patient. Now, the biggest part is there empathy in artificial intelligence and telemedicine? We all talk about it, but you see the new generation robotics seem to be having empathy. They have a lot of emotions that can be displayed on their face. It looks almost real as compared to what is happening. And these are beautiful movies which show that emotions or empathy can be shown in these newly created robotics. So it is likely that these will play a big role. And we have science fiction movies like this, we seem to get translated very rapidly into clinical practice, wherein human natural intelligence could be augmented with artificial intelligence. And it is likely that by 2025, then man becomes immortal. By the incorporation of these various technologies, and I'm sure artificial intelligence and telemedicine will play a big role in clinical medicine of the future. Thank you once again for the patient here.
Thank you, sir, for the excellent presentation. We know you contribution to laparoscopic.
Sorry, I can't hear you there.
AI.
Uday, I think you're muted.
Thank you very much, sir.
Sir, thank you very much, sir, for a wonderful lecture and taking all of us to the future. And really, the future looking is very bright, sir. In fact, the artificial intelligence.
I think you're muted, Satya.
Can you hear me, sir? Hello?
Yes, we are hearing.
Mohan, can you hear me?
Yes, I can hear you very well, sir.
Sir, are you able to hear me, sir? Okay, I think Dr. Uday, Dr. Jivaras sir is not able to hear us.
Yeah, I can hear you now. Yes.
Can you hear me, sir?
Yes, thank you.
Yes, sir, thank you very much, sir, for a wonderful lecture and taking all of us to the future, how it is going to be with artificial intelligence. Then I have one question, sir. By looking into the artificial intelligence entering into the surgical field, till now we used to recognize the doctors with their skills, with their manual skills, how they are efficient. Is this artificial intelligence is going to replace the surgeons in surgical area?
This is a very good question, Satya. Actually, so far, suppose I say I'm technically good, it has been a subjective evidence to tell me that I am good technically. But what we need in future seems to be objective evidence to show that I am technically good. Now, how can I be objectively be certified that I am good for the patient? It's going to be the artificial intelligence that I keep uploading my videos onto the thing. And based on the data that is collected from across the globe, it will compare myself with other people across the globe and grade me as a mediocre surgeon or a good surgeon or an excellent surgeon. So far, we have all been thumping our chest saying that I am the best person available around. But now, AI will come in a big way to tell globally whether you are good or not. So it is going to be an objective evidence in future. And like in future, people are going to ask for objective evidence. It is no longer that I don't think people will realize on what is seen on the thing. They would look for more objective evidence to see whether the concerned clinician is good in clinical practice.
Thank you very much, sir. Dr. Uday, please go ahead.
Nice. And your contribution to now in AI. Next presenter is Fumihiko Yokota. He is PhD, MPH, Associate Professor from Kyushu University Institute for Asian and Oceanian Studies. He received a Master of Public Health at University of California, Los Angeles in 2001 and PhD in Public Health and Tropical Medicine at Tulane University in the US in 2007. He has more than 15 years of epidemiological research experience in over 10 countries, including Indonesia, India, Bangladesh, Thailand, China, Malaysia, Papua New Guinea, and US. Fumihiko Yokota, please.
धन्यवाद, नमस्ते। मेरा नाम योकोता है, आपसे मिलकर अच्छा लगा। My name is Fumihiko Yokota. Thank you so much for having me and giving me opportunity to share my presentation today. I would like to thank all the AATS committee members and all the distinct doctors and professors. A special thanks to AIG Hospitals, Hyderabad, and the TEMDEC, Dr. Shimizu, Professor Shimizu, Professor Moriyama, and all the TEMDEC team, Kyushu University. Please, I would like to share my slide. So today's my presentation title is a portable health clinic, online healthcare in super aging society in the post-COVID-19 era in Asia. On behalf of our portable health clinic research team, I showed all the team members' photo in the bottom of this slide. I am very grateful to present today at the ATS Symposium. Today, I would like to share three things. What is portable health clinic and our research team and partners, and how PHC different from other telemedicine systems, and why PHC is important for super-aged society in with post-COVID-19 era in Asia. This graph, this slide shows the PHC team and the partners in Asia since 2010. Our team has been conducting a portable health clinic research more than 10 years at the Kyushu University. We have 6 research partners in Asia. Biani Group of College in Rajasthan, India, since 2016. Originally, this research started with collaboration with Grameen Communications, Grameen Group in Bangladesh. And we have Asian Institute of Technology in Thailand, Gajah Mada Universities in Indonesia, University of Malaysia, Sabah in Malaysia, and the Chinese Center for Disease Control. So in Kyushu University, we have advantage that location in Fukuoka is more closer to the major cities in Asia compared to Tokyo or other part of north part of Japan. So within 5,000 kilometers, we have 6 partners. So first, I would like to share a 2-minute video to introduce our video. So I would like to change the slide. So we have, sorry. So this is our portable health clinic website. And we have a short introductory video translated in different languages, including Hindi. So I would like to show the Hindi version.
As a land of 57,000 square miles of Bangladesh with more than 160 million populations, people are suffering from various health problems. To overcome the doctor shortage and inadequate medical facilities in the rural areas, portable health clinic (PHC) is a revolutionary invention. This is a joint initiative of Kyushu University, Japan, and Grameen Communications, Bangladesh, to ensure the universal health coverage (UFC). This will bring the healthcare service to the doorsteps of the unreached communities of the developing countries in an affordable and sustainable way. BHC doubles physical checkup using automated medical equipment and transfer the vital data directly to the call center. Doctors for their reference. BHC measures BMI, blood pressure, body temperature, diabetes, globin, urine tests, etc. Based on the test results, BHC triage system classifies subjects in 4 categories: green, yellow, orange, and red. Orange and red category subjects are to be connected with the call center doctors through video conference. BHC has been primarily developed for providing basic healthcare services, with a special focus on non-communicable diseases, NCDs. What is the main cause of deaths? However, there are many patients who need other types of secondary or tertiary level of treatment. To address these demands, BHC has gradually added new modules like telepathology, tele-eye care, and maternal and child health care. Recently, COVID-19 module has been added to tackle this pandemic. Other than Bangladesh, BHC has been replicated in countries including India, Indonesia, Liberia, Malaysia, Pakistan, and Thailand. The global healthcare team of Kyushu University has been continued. Partners in other countries for the development and expansion sustainable development goals, SDGs.
Thank you very much. So I'd like to come back to my slide. So as you can see from this video, the portable health clinic is a real-world, solution-oriented, transdisciplinary approach services. So it's different from other telemedicine services because this telemedicine service focus primarily people in rural area, who are relatively low or middle income people. And it's really try to solve the social problem. So it has a population management approach, which means we conduct basic health checkup for non-communicable disease. And those who are in need of any particular disease, which classified into 4 triage category: green, yellow, orange, or red. We will provide the telemedicine right away based on health checkup result. So it has a PHC box component, device component, hardware, and a telemedicine tablet-based software system, combining with a triage system and the telemedicine service. As a research, we will use the transdisciplinary approach. So I would like to explain what is transdisciplinary approach. This slide shows the transdisciplinary approach. It means that beyond the hospital or the laboratory, we will conduct our research in a real world, in a community. And we involve our research very beginning of the proposal or designing stage with non-academia stakeholder, such as government, local governments, or local industries, so that we can have a win-win approach and learning from the society, non-academia. And then we will conduct the research together with non-academia stakeholder, social stakeholder. And then we will apply our research findings to solve the feedback to the society to solve the problem. So this kind of right side explains what is the transdisciplinary approach, meaning that comparing with one disciplinary research or multidisciplinary research or participatory research or interdisciplinary research, this transdisciplinary research involving social stakeholder, non-academic stakeholder, and also within the university, we involved the different disciplines, not only clinical research, but also the epidemiology, social science, engineering, and biostatistics, those kind of things. So why this telemedicine PhD will be important in Asia, projecting the future? This graph shows the percentage of the population who are aged over 65 years old in Asia. The y-axis is a percentage, and the x-axis is a time here. And each of these colorful lines is a country. For example, the red is Japan, and then blue is India. So this graph says that by definition, if the more than 70% of the total population are 65 years or older, it's considered as aging society. If it is more than 14%, it's called aged society. But if the percentage is exceed 21%, it's considered as super aged society. So by 2050, most of the Asian countries, such as Japan, China, Singapore, Thailand, these countries will experience, all of them are super aged society. And even in India, Bangladesh, Indonesia, those countries will be aging or aged society. So in the future, at the COVID-19 era, it is expected that the loneliness or depression will be increased, the anxiety and fearness, dementia, lack of exercise. In those kind of society, online healthcare will be our new normal in the post-COVID-19 era in Asia. So in this portable health clinic system, we have this slide shows a basic triage protocol, meaning that each of the classification is based on the WHO criteria for BMI, waist, blood pressures, and hemoglobins, blood cholesterol, and the blood sugars, those kind of criteria. And in the box, we have different types of devices purchased in the local context, most culturally, socially appropriate device. And in the future, we are expanding this non-communicable disease health checkup plus a communicable disease, such as COVID-19 health checkup or AI diabetic retinopathy or other AI photo devices, detection devices, diagnostic devices. So this is one example in China that they use the portable fundus retinal camera using AI. So based on the AI photo, they can automatically detect the diabetic retinopathy. And using virtual reality technology, they are trying to diagnose the depression. And also they can provide a treatment for mentally disordered patient using VR. This slide shows the new COVID-19 and other infectious disease diagnostic tools using isothermal RNA DNA amplification technology. This is called, this is similar to the LAMP technology, but it will be much more faster and more affordable and on-site point of care detection we can do for the infectious disease. So that's the difference from the LAMP or PCR, which is much more expensive and laboratory based and take a long time to detect. So we have three different type of PHC service flow. This is called a mobile health checkup flow that we can go to the community with mobile bus, or we can set up the local community camp, health checkup camp, so that people come to check for their health status. Then we will do first the registration and the basic questionnaires about a patient. And then we can do the health checkup for the non-communicable disease and the communicable disease. And using the PHC apps, all the information will be entered. And based on the data result, those who have orange or red, those who have some issues, clinical issues, they can receive the telemedicine, doctor to nurse to patient. It means that the patient can talk to the doctor with the assistance from the healthcare worker who are at the health checkup site. So the data immediately will be printed and the e-prescription will be handed out to the patient, and the healthcare worker explain to the patient so that the patient can go to the pharmacy to purchase the medicine that's necessary. And after that, the patient can be followed up by the remotely by the doctor. This is one flow. And second flow is the health facility-based flow as a routine service. And the third one is the home-based care, including some high-risk area and hotspot. We can target that kind of high-risk or hotspot who are most vulnerable area, and we can do the health checkup and follow the same facility. So actually, these services are implemented during the COVID-19 pandemic in Indonesia. They did the facility-based, not facility-based, they set up the community camp or home-based approach for during the COVID-19. This is another example in Bangladesh. They use portable health clinic for the mothers, pregnant women, those who are afraid or fear to go visit the health facility during the COVID-19. So during the lockdown, we will make a phone call based follow-up with the pregnant woman. And after the lockdown lifted, we did a home-based visit to health checkup with infectious control. And same as Malaysia. So based on these activities, cumulatively, we have more nearly 50,000 patients used for PHC service. And the next challenge will be how this service can be accepted and used more widely by the people who are in the low or middle income countries. Because this is still the research-based service, but as a real service, social service, or even in a social business, as a social business service, the challenges are people in a low or middle income countries, peoples, they are reluctant to do the health checkup until they got some kind of clinical symptoms or pain, or until they really feel the necessity of the health checkup. So that's our challenge we are facing. Thank you very much for listening.
As much as possible.
धन्यवाद.
Okay, thank you, Professor Fumiko. So if there is any question or any discussion, please, now we can open the floor for 1 or 2 minutes.
There is no question.
Okay, so now we are running out of time, I think. So, Mr. Mohan,
yeah. So,
will you please?
Very good, informative and interesting keynote lectures given by Dr. Suji Shimuju about the Asian Television Symposium, Past and Future, and Dr. G.V. Rao, Artificial Intelligence in Telemedicine. Then Professor Fumiko Yakoto about Portable Health Clinic for Asian Developing Centers. Now we are move on to session 3. Mr. Satya, I will take over this session. Thanks to.
Thank you, Mohan, Dr. and Dr. Uday for running this session very successfully. And I think all our engineers enjoyed this session. A lot of inputs we got from the top speakers. And that public health clinic was very nice. In fact, that is very useful in Asian countries, which are all developing countries. I think even we are also looking forward for that system. Maybe I will get in touch with Dr. Yokota for this future. Thank you very much. And next session is going to be the role of telemedicine during COVID-19, session 3. May I request Dr. Jeffrey and Dr. Tawachai to take over this session?
Hello, Satya, can you hear me?
Yes, sir. Please go ahead, sir.
Okay, so good afternoon. It's good afternoon here in the Philippines. It's already 1:30 in the afternoon. I think I'll be joining with Professor Tawachai. Is he around? Yeah. Satya, I think Professor Tawachai will join us later.
Yes, sir. Maybe we request you to share your experience from Philippines, sir.
Okay, maybe I could, yeah. Okay, I will start my presentation. Then after this, we'll proceed with the next presentation. So I'll just share my screen. Okay, let me see. Okay, can you see my presentation on my PowerPoint?
Yes, sir.
Okay, so I'll proceed. So good afternoon, everyone. I'm Dr. Jeffrey Domino from the Philippines. I'm connected with the St. Luke's Medical Center as my institution, as well as the Telemedicine Network of the Philippines. My talk for today will be about telemedicine, our learning experience going towards our post-COVID pandemic era. So I think we all have the same experience when in terms of the global pandemic. There was a lot of chaos, no? A lot was really a lot of restrictions, such as going to stay home, a lockdown. There was a lot of sickness. There were deaths. There were uncertainties on how to treat. So the telemedicine network of the Philippines at that time, we used the platform, no, for the response in learning how to approach, how to be prepared when the COVID infection will come to our country. So we were able to have several teleconferences together with the different hospitals all around the country. And with the support of TEMDEC, we were able to share the experiences, share our best practices in the preparation for COVID, as well as the latest, at that time, the latest treatment regimens in how to manage COVID-19 infections, as well as the realities of what could be a fatal or a chaotic world if we don't, if we don't put together or if we don't collaborate together in managing the COVID. So with that experience, we noticed that there was a lot of enthusiasm, a lot of interest, and there was an increased utilization of telemedicine during those early days. Okay, and because of this, our network facilitated doing a lot of webinars for both doctors, societies, and different specialties as well. So we were able to facilitate and even teach the doctors on how to perform teleconferencing. And now they're running their own webinars. And this was actually facilitated by our group, the Telemedicine Network of the Philippines. Not only just the webinars, the approach in our country that there was national policies and regulations in telemedicines. And you can see how the rise of utilization of using telemedicine in our country, especially from the doctors. Hence, there was a lot of, there was already a move at the national level to have a e-health vision that will create policies and regulations in using telemedicine, especially in teleconsultation. And this came from our government policies and the universal healthcare, as well as the Department of Health's memorandum circular on telemedicine. So in other words, the support of the government came, especially during that time of the pandemic. And we also studied our doctors. So we sent a survey and on the use of telemedicine. And if you can see here, what was the main purpose of using telemedicine, and the priority or the most utilization was more on teleconsultation. And this was followed by meetings or online webinars or teleconferences. And then followed closely by an online education, because at that time, face-to-face school was stopped. So there was a continuous online courses or online learning as well. And this was also followed by telementoring and training how to use the platform at that time. Same observation here. You can see that even before the pandemic, there was really a low enthusiasm or use of teleconsultation. But during the start of the pandemic, there was a rise in the use of the pandemic. So rise in the use of the teleconsultation during the pandemic. So there was really a rapid shift. And I think this was reflective with the other countries as well. So what were lessons learned during that time? That with the use of the telemedicine, we were able to respond to the needs of the pandemic in terms of preparation, learning learning the latest treatment, learning the capacity as well as the resources that will be needed. And it did help other hospitals, especially those at that time, there was no COVID yet, but now they were able to prepare from that. It also increased or expanded our growth of the network. Before, we were only a few hospitals connected, but because of the pandemic, a lot of hospitals wanted to join and connected with the activities the telemedicine network has done. And because of this, we were able to reach to the different areas around the country. And another lessons learned, that it was now easy to spread the information. No? It was getting new data at that time can already be sent or can already be shared to the different remote areas, those who have connected with our network. No? So the shared information on COVID infection really helped in the preparedness of the different hospitals, and even share the experiences of the different hospitals who already have the COVID infection at that time. And some hospitals, especially the private hospitals, even shared the best practices. As we were, the big hospitals or the big institutions develop good policies, hospital policies on how to manage, how to be prepared, how to maintain supply chain, how to expand and use the internet or the online resources. Again, this was all shared, and a lot of hospitals did benefit from this learning as well. Even the doctors learned the use of telemedicine, the use of the platform, the different softwares. There was a lot of commercial softwares that were available at that time, and I think you know that Zoom is one. There was a lot of other softwares that were available, and a lot of doctors were hesitant to use one platform to the other, so nobody knows which one would be best. And another learning also that they noticed that remote conferences has really increased. Doctors can now attend more meetings even when they are just at home. So again, these were the lessons learned at that time. But there were challenges, of course, like the policies, the regulations in terms of patient safety, malpractice concerns during teleconsultations, even the limitations of telemedicine, the quality of care. As you know, since it's a remote or online consultation, the teleconsultation, especially at the part of physical examination, is very limited. So again, we learned, or the doctors learned, how to adapt on that time. There are ways to do some virtual physical examination, and it indeed progressed or evolved on how to do physical examination, and now being taught to the students as well. Another challenge was the payment reimbursements, as the insurances, other online payments were not really integrated in teleconsultation. Okay, so there was no standards about that. The digital payment was not standardized, or was not equal or not uniform. So again, these were the challenges that were faced during the time of the COVID, as we were facing the problems of the pandemic at that time. We asked the doctors, the healthcare workers on how effective or what provided them the effective assistance or support in learning the use of telemedicine. And surprisingly, most of them were self-taught. They learn it by themselves. They learn it by observing. They learn it by trial and error. And in other words, the ability to adapt, no, in a lot of healthcare workers really superseded that interest, and eventually learned how to use this type of platforms as well. So again, the learning really was enhanced with the use of our teleconferences or telemedicine as well. And to really expound on that, even teleconsultation during online training, like in my field of minimally invasive surgery, we use telemedicine and teleeducation, especially in different specialties. We learn how to use real-time interaction with multiple attendees, from few hundreds to a lot, to almost 1,000, through an interactive online platforms and softwares. We even learn how to do our online skills workshop. If you cannot do it face-to-face, you can do it remotely or virtual. Here you can see how we teach or how we instruct our trainees on, and we can monitor them on how they perform them. So that way, the online learning continues despite the limitations or the restrictions done by the pandemic. So again, we learned, no, on how to adapt, especially in even during the teleeducation. Here you can also see the remote live endoscopy, and I think this will be shown by other presenters as well. You can see that even a remote live endoscopy demo, and then you can see that the gastroenterologist was showing a live presentation of the procedure in doing endoscopy, teaching them and learning them as well with how they will need to learn this type of procedure. No? And even during the time, they were able to have interactive forums as well as very good discussions with this remote online learning, and as well as a demo. They also learned how to do teleconsultation using like this one in minimally invasive, wherein conferences were being done. We call this a hybrid setup, wherein you can see that the participants are actually on different countries, but then again, different regions of the country. But then again, the main event is held in a small room or in a small portion of the place, and then they're able to do an interactive discussions and demo as well during teleconferences. Because of also this pandemic, teleconsultation such as telementoring was also now being used. Trainees are performing their procedures in minimally invasive surgery in the OR, but the consultants or the expert panels are not on site, but are monitoring and teaching them remotely. Again, this has been already being slowly adopted and being used, and that way, no need to crowd within the hospital. Even if the patient is it's a COVID procedure, a patient with a COVID patient with a procedure, the consultant or the expert panel can still guide the trainees as well as the doctors during it. So, what were lessons learned on this time? That online education was expanded its use during the pandemic, and we also noticed that there was a good collaboration of medical societies, hospitals, and even other even health institutions with the use of the telemedicine. Again, it actually broadened the network. It expanded also the international network, and with this, there was a good exchange of expertise, We were able to invite international speakers, international experts to the different online conferences that were done. So there was a good exchange of expertise from international centers. And then it even afforded a virtual reunion, seeing people you know, and you've seen them in the virtual or online platform. And of course, the use of this also expanded to different specialty in the fields of different specialty in medicine. So again, these were the lessons learned that we were noted during the pandemic. So what's next? This is the latest, as of yesterday, the latest number of COVID positive here in the Philippines, and it has really gone down. And now we're averaging at less than 1,000 per day. The positivity rate has also really decreased. So I don't know if we're seeing the end of the pandemic, and we hope that it's really going to continually go down, and hopefully it will be the end. And then because of that, we asked our doctors, once the pandemic is over, will you still use the use of the telemedicine or teleconsultation with your patients? And with this study, you can see only 16.2% will not use teleconsultation. About more than 50% will use continue to use teleconsultation even after the pandemic. So we asked, and this study has shown that how about on different specialties? So it shows here that not all specialties will continually use it. There are certain specialties that would really use the telemedicine or teleconsultation even after the pandemic. And you can see that most of the specialties that really are involved in continuing the use of telemedicine are the ones with dealing with chronic diseases or diseases that are long-standing problems. And you can see that most of the surgical patients are less compared to the chronic diseases of the patient. So you can see that like psychiatry, substance misuse, endocrine, rheumatology, gastroenterology, neuro. So these are the specialties that might continually or have a high increase in use of telemedicine after the pandemic. Another study done here in Singapore, most recent care that received utilized medicine, you can see that even on different outpatient, telemedicine is still being used. Either they use it using telephone or teleconsultation, video and audio-video teleconsultation. Again, it will continue as well. So with the latest digital gadgets that are coming up now, especially with AI capabilities, as mentioned by our previous speaker, G.V. Rao, who's also a MIS surgeon, the challenges are there. We may have a lot of different softwares that are coming, commercial ones, different innovations. Again, here in the Philippines, our challenges are the following, like the availability, access, even the signal strength and stability of our internet. It still holds to be one of the challenges. The compatibility of the softwares, it may be available to the different countries, but once we use it or integrate it to our system, again, that's another issue, especially in those hospitals that are just starting to develop their electronic medical records. How do you integrate it now to these gadgets to your hospital if you're going to use that? And then there's also the challenge about regulations, limitations like the data privacy, the legal and ethical issues, and of course, financial and cost viability. Of course, the cost. And will it be an added cost to the patient? So again, those are the things that we need to check. And patient adoption and education, which I will talk in a while. So with all of this, gadgets, telemedicine use, the adaptability, eventually, where are we going on which directions? And I think it's about making or developing a new ecosystem of how to use telemedicine here. And you can see that on different on the different sites, on different fields, telehealth, e-visits, and even the use of telemedicine at home, home monitoring, wellness. These will all use the use of telemedicine or telehealth with this type of ecosystem. And so therefore, in summary, what lessons are learned? No? So eventually telemedicine or the use of telemedicine will continue. And definitely based on the studies, we will expect to have more use of telemedicine, especially in teleconsultation. The specific medical specialty that utilize telemedicine is not equal. Number one, learning also to know which of these specialties will use, and maybe we will be able to know which of the area of telemedicine we will be able to augment or need to learn more. The proliferation of these health gadgets, again, this is a challenge because there will be new and a lot of different options now, but which one to use? Again, that's another challenge that each of the doctor as well as institution will tackle. No? As we learn that these are already being offered. And of course, now it's the expansion of telemedicine to the community-based. We go up to the community. Because of the lockdown, because of the quarantine, we learn that we have to go through, or we have to go beyond the hospital in terms of caring to our patients. Hence, the challenge is ahead. Again, we need to have updated regulations, policies from the government to really cover both ethical as well as legal issues. The doctors will continue to need to learn how to adapt these platforms, and also how to really go with the reimbursement as well as the insurance coverage. Again, these are actually just these are just challenges. And the innovations that are coming up for the different specialties. You've seen how innovations are coming up. I think we have the adoption of these innovations. Again, that will be a challenge. And then let's not forget the patient experience. I think even with despite all the learning, the workshops that we do, the teaching with our doctors, I think we also need to teach our patient. Because even if we have a very good gadget, even if we have a very good system, but the patient will not learn how to use it, again, that will take time for adaptability. So my suggestion is also to really address patient experience with that. So in conclusion, telemedicine will continue to evolve, and its use should be an integral part in the developing of a new ecosystem within our community. So with that, I'd like to thank you for listening, and I'll be happy to answer any questions. So I think that's it. Thank you very much, Satya, and good afternoon to everyone.
Thank you very much, sir. It's a wonderful experience from your end. I think in your presentation, I could see
Satya, I think it's Dr. Professor Tawachai already here? Not yet.
I don't think so, sir. Sir joined now.
Oh.
I have a question, sir. Can I ask?
Cannot hear. Okay. I can hear you now. Okay.
Yeah, in your presentation, I saw this. I think almost 70% of the doctors they don't want to continue with the online consultations of post-pandemic. So how do you take it, sir? Then only because of the pandemic we are on this telemedicine, or the trend is changing towards telemedicine?
Yeah. So it's like this. I think you can also include cultural part there, Satya, because people in the Philippines, they really treasure the face-to-face consultation with the doctors, and they want that. Second, most of our doctors, the age of our doctors are actually a bit high, so the adoption of this use is a bit slow, though they are using it. But based on our study, they really still want to proceed with the face-to-face. However, they learn that once the system is there, meaning even the reimbursements, the payments, the ease, the availability, the internet stability are all there, and maybe it will be sustained, and a lot of them will really continue to use of it. So again, there are some challenges about this. Thank you, Satya.
The acceptance of the patient is okay, sir. The patients are accepting telemedicine.
For acceptance of the patients, the initial acceptance was a bit hesitant at first. So
Okay.
that's why that was one of my talk was the patient experience. No? But the patient acceptance in telemonitoring, meaning after they have the services from the hospital, when they are monitored once discharged, they really appreciate that because they don't need to go back to the hospital. And remember, they are afraid to go to the hospital because of it. So they appreciate the continuous care using telemedicine. Again, that's where telemonitoring will come in.
Thank you, sir. Thank you very much. Very wonderful lecture. You should take it forward with another talk, sir.
Yeah. Okay. So let me see. I'm looking at the program. I think the next. Can you hear me, Sacha?
Dr. Rivanti. Dr. Rivanti.
Yeah. I think Doctor will have another presentation from Indonesia. Is that right? It's
Yes.
Dr. Riwanti Eschasari.
Yeah.
Good afternoon.
Good afternoon. Yeah, hello.
Hi, Doctor. Go ahead,
yeah.
please.
Okay, I will share my screen. Okay, can you see my screen?
Yes, Doctor. Go ahead.
Can you
Is it moving? Is it moving the screen to the next slide? Because yesterday I have a problem.
Yeah, can you press the slide
Okay.
presentation? Yeah, you have to.
Can you go to presentation mode?
Yes, sorry.
Can you just make it in presentation mode, slideshow?
Oh, okay. In my screen is already slideshow. I think there's a problem here. So it's not in the slideshow in your
Dr.
screen.
Rivanti? Dr.
Yes, yes.
Rivanti?
Yes.
Could you stop sharing and start sharing again? And when you choose the sharing, please select your display.
And then, okay.
Okay.
Is it in the slideshow?
Yeah.
Okay.
Thank you.
So let me try first. You see it's moving to the next slide?
Yes.
Yes.
It's moving now.
Okay. I think it's worked now. Okay, sorry. Yeah. Yeah, so first of all, thank you very much for the invitation for me to join in this special meeting. So I'm Riwanti Estiasari from Faculty of Medicine, University Indonesia, Cipto Mangunkusumo Hospital, Jakarta. In this short presentation, I will present about the role of telemedicine during the COVID-19 Indonesia experience. Okay, so this is the situation, COVID in Indonesia. I think most of all already known, and we faces almost the same situation. So Indonesia faced the second wave with a very bad situation from July until the October. But right now we everything is almost returned to normal. The number of COVID is decreased significantly, and yeah, and we hope it's not return back to us again. This is the last, no, not the last. A couple of days ago, the number of cases, number who are healed, and also who are not survived. So we know by the COVID, there's a limitation of mobility. So our government apply the community activity restriction enforcement. So we cannot do our activity as usual. And there's a concern of COVID-19 infection in hospital. So patient tends to delay their visit unless in an emergency situation. So if there's no emergency situation, if they still can hold their symptom, they will stay at home. And many hospitals also shifting for COVID-19 cases. So the occupancy majority is shifting for the COVID-19 cases. That make many people try to delay their visit to the hospital. Another problem is that during the pandemic, there's many financial difficulty in Indonesia. So everyone is gathering, involving in this community activities restriction enforcement, not only in hospital, but also in the community. So due to the limitation of mobility, so the access to medical care is shifting via the telemedicine. So the telemedicine in Indonesia is, we can see here, there's 4 COVID-19 cases and 4 non-COVID-19 cases, and also we have consultation and discussion between institutions, and this is including for the education. Before the COVID era, the telemedicine is not so popular in Indonesia. In our hospital, we don't have a telemedicine service before the pandemic era. So our government provide the telemedicine in COVID-19 cases, but it's only for the asymptomatic or mild COVID-19 with self-isolation. They are working with 11 platforms of telemedicine to cover so many COVID cases in our country. This service is free and it's connected to the free medication also. However, there's still many difficulty because many patients said that it's often difficult to access. Maybe it might be to the massive user that use the platform, even though they already have 11 platform for the telemedicine. And then the other problem is the connection between the telemedicine to the pharmacy. So it's still difficult to get the medication from the digital prescription. And besides the telemedicine that provided by our Ministry of Health, many hospitals and other health providers also try to provide the telemedicine. Also for the COVID-19 cases and non-COVID-19 cases. Of course, it's only for the asymptomatic or mild COVID with self-isolation. Telemedicine that provided by the hospital usually bound with a package with the medication, laboratory tests, and also home visit. And it is usually more expensive. Depends on the package. It can be very expensive also. And they develop many platforms for the telecommunication like Zoom, WebEx, and other platforms that they try to develop by themselves. And in non-COVID-19 cases, this is also something new for us. This is provided by hospital or other health provider. The platform is vary from the simple one like a video call with WhatsApp, and then another video telecommunication service like Zoom, and then another platform like that. And also many of hospitals also try to establish their own platform for the telemedicine. This telemedicine in the COVID era is very useful because it can help patients to consult with doctor without leaving their home. and the patient can meet even with the subspecialty physician from the distance. You know, geographically in Indonesia, it's sometimes quite difficult to see a subspecialty physician if they are in the different province. So the telemedicine gives us solving for that problem. And for the medication, it can be sent by the courier from the hospital. Of course, this technology have a limitation. Having communication via the telemedicine is reduced our relationship with the patient. So the patient-physician relationship, we cannot feel what the patient feel. Their body language is limited. Sometimes we need to know when we do a communication with our patient. And also the other issue is about the privacy and confidentiality while we are doing the telemedicine. And then in Indonesia, we still don't have a good law enforcement for the telemedicine. So during the COVID-19, there's so many discussion about the law enforcement for the telemedicine. Many institute try to, or association try to prepare the law enforcement for the telemedicine. And the technology adaptation. Not all doctors can adapt it to the technology. Sometimes it's quite difficult and need assistance to the telemedicine, and also the patient, even though they can connect it to the Zoom as example, but then after that there will be another problem during the telemedicine process. So this is in our hospital. It started in around December 2019. The first using the Zoom software, and it's not connected to our medical record. So doctor must come to the hospital, sitting in the clinic, and the hospital will provide the Zoom with the link. Then they will connect it to the patient who already registered for the telemedicine. And then we do the consultation with our patient. And then after that, we have to fill the medical record, the electronic medical record using the hospital PC. And after that, we can prescribe the medication electronically. And our pharmacy will send the medication by courier to our patient home. If the patient is in Jakarta, of course. If in different city, and it's really more complicated. Sometimes it cannot be done. This is the difficulty. Since it's not something that we are used to telemedicine, so the number of PC in our hospital is not, it's don't have the webcam. So there's a limitation number of PC that we can use for the telemedicine. Sometimes doctor have to queue if they have a patient for the telemedicine. And not all physician or hospital staff can easily adapt to the technology. Mostly it's in the beginning when the first time we use Zoom or another application. But after 1 year and now, I think many doctors already familiar with that kind of telecommunication. And there are also a connection problem. Sometimes the connection is not good, so the patient, it can be in the hospital side or in the patient side. And then the other is about the communication issue. And the limitation in information transfer, we cannot do the physical examination. It is very limited. Of course, we can do some of the physical examination, but not all. And sometimes the patient, not all patients understand how to send their, just in case their laboratory result or the MRI result, the picture in DCOM, in DCOM version. It's quite difficult to make the patient send that kind of file because it's a huge file usually for the MRI. And the other is the ethical issue. So after 1 year, our hospital try to make a other platform. So we already have an application. We call it SiapDoc, and it's connected to our medical record. and we can prescribe using this application. And it also can be accessed from hospital or outside hospital. It needs times more than 1 year to improve the quality of this application. But I think since last month, we can use this application quite easily. The problem is not only in the doctor sides, but also in the patient side. Many patients in the beginning is complaining with this application because it's very difficult. But now, after the improvement, we can use it more easily. The other aspect of the telemedicine is in conferencing and education. So besides for the consultation between doctor and patient, the telemedicine also have a role in the knowledge transfer, like in the teleconference. This is the teleconference that we have far before the pandemic, which is since the February 2017. And it's involving many institutes in Indonesia. And this kind of activity is encourage Indonesia side to improve the quality of neuroimmunology knowledge and skill. And we already done until the 29th in last October. We also have many medical webinar using the technology. And I think it's almost the same in many countries, that education method also shifting with the online method, including the medical education. So for our medical students, they have, sometimes it's a full online in 1 day, if there's only a lecture. And if they need a hands-on activity, then they will come to the hospital. But with the limitation number of the students. And if they need a discussion or another activity like that, then we will use the online platform. So for conclusion, the telemedicine in Indonesia brings many benefits, especially in the COVID-19 pandemic. It still faces many difficulty and issues that need improvement. And the telemedicine will be used even after the pandemic, considering the benefit that it can do. Okay, I think that's all that I can present here. Thank you very much for your attention.
Thank you, Professor Riwanti. Any questions from our panel or audience with regards to the presentation? Yes, Kuriko, go ahead.
Thank you, Dr. Riwanti, for your very practical presentation. So I am really interested in the telemedicine activity in University of Indonesia, and after 2020, you installed a Sharp Doc, the special application for telemedicine. So is that system linked to EHR, or is the system for just the patient booking and have the remote telemedicine activity?
You mean the application for the teleconsultation?
Yeah, is this connected to EHR or not connected?
To what? Sorry?
Electronic health record.
Yes. In the beginning, no, but since it's very difficult, sometimes doctors don't have time to go to the clinic, and the need for the teleconsultation is quite high. So our hospital try to improve it, and now we can connect it to our medical record. So after we do the consultation, there's a link there that connected to our medical record. Then we can fill. So they already make a box there. Then we can fill the what is the symptom and everything. And even with the prescription, we can do the prescription from the application.
Okay. Then using the system, doctor doctor can connect from their home, or they need to be in the hospital.
doctor can do it at home.
Oh, in practical, in your activity, some cases, doctor can see the patient from their home.
Yeah, in the certain time, then they can do it at home. If the time is not, it's very limited for them to go to the hospital and the patient need to consult, they can use the application at home. But many doctors prefer to do it at hospital during their time work.
Yes, of course. Thank you for your information.
Okay, thank you very much, Kuriko, and thank you also, Professor Riwanti, for that excellent
thank
presentation.
you, Professor Jeffrey.
Thank you. So we'll move on to our next speaker. Our next speaker is coming from Russia, and may I call on Professor Evgeny Nikonov. Professor Nikonov, are you already connected with us?
Sir, I think we should move ahead with Dr. Uday Koiral's lecture.
Okay, thank you, Sacha, for that. So we'll move on to the next speaker from Nepal. May I call on Dr. Udaya Kuraila.
Okay, thank you.
There. Nice to meet you.
Hi,
from
nice
Nepal.
meeting you. So I'll be sharing the screen.
Okay, go ahead.
Can you see my screen?
Yes, go ahead.
Thank you. So today I'll be talking about the role of telemedicine during COVID in Nepal. When we talk about telemedicine, we can't forget these two eminent figures in Nepal, Dr. Mahavir Pun and Dr. Saroj Dhital, a mixture of technology and medicine. So first, telemedicine, actually long-range testing was done in 2002. And we had many rural centers who were slowly connected to our telemedicine center. But it was a very slow process. This telemedicine development was very slow, and we were not being able to make the people understand the importance of telemedicine until COVID. And during COVID, all the webinars, all the online classes, all the telemedicine services actually had boosted up. And there was no actual policy for telemedicine. And even for COVID care, there was not clear policy. So government has to do rapid assessment, rapid improvement, and rapid implementation of the telemedicine guideline and all the policies related to telemedicine services. And I was lucky to be involved in performing the telemedicine guideline for registered medical practitioners in Nepal. Our medical association also opened up the Nepal Medical Association Telemedicine Center in association with the Chamber of Commerce. And we started providing telehealth services, especially to the people. First, it was for awareness, and there was fear among the people, and we had to counsel a lot to the person, and even for testing, then confirming, for diagnosing, and for treating, all the steps had to be consulted through telemedicine. And we also perform this COVID surveillance. And there were some non-government organizations who were also providing these telehealth facilities from home. They were providing these free services. They provide call numbers, and through Viber, WhatsApp, or other teleconferences, they were providing the services. Some were through some centers, and some were providing the services personally as well. So we all could feel that telehealth was growing up in Nepal, and actually it boosted up during this COVID period. And all felt the need of guideline, the need of policy in the government level also. And now they are slowly amending the clear guidelines and policy for the use of telemedicine. Still, the telemedicine is still taken as, but now is developing to other telemedicine tools as well. Use of there's the at the point of care using telemedicine, and other setups like portable healthcare telemedicine setups. Even in nursing care, this telenursing was also a new thing to Nepal. We had to invite so many nurses to introduce telemedicine, to educate about the telemedicine, and now slowly this nursing care is also using telemedicine for rural area as well as for the urban area. Even in the health home care facilities, they are using telemedicine now. And in ICU setups also, many hospitals has started, especially teleconsultation with the these critical care consultants in ICU. During second wave of this COVID, there was a bit chaos. There was no oxygen supply available in the hospital. All the hospitals were occupied with patients. And in that time also this telehealth, telemedicine and digital health services had risen, and many private hospitals also were providing these telehealth services, charging the patients certain amount, and they were providing the consultation for home isolation, home care, and also coordinating with the other institutions for patient admission, transfer, etc. And we also had online regular classes because the COVID here, it was changing day by day, and there were new medicine, new procedures coming up. So we had to learn from each other, and even like other specialties like orthopedicians or gynecologists or public health, all were involved in the care of COVID. So we had to exchange the ideas, and so these online classes were also boosted up. And we could see many advantages of online classes, classes for residents. So it was more fruitful, more focused, and more comfortable, without any noise, without any disturbance. So even after the COVID now, many classes are going online because of these advantages. We had technological difficulties. We had some difficulties in psychological aspects and other side activities, how to track. But now it's improving, the technology is improving. So even after COVID, now we are continuing with some part with online classes, and we are being more comfortable with this type of online equipments as well as procedures. we were going to organize this APAN session in Nepal, but we should say we were unlucky to postpone that because of the COVID, but we successfully organized rural healthcare session of APAN 50, 51, and even 52. So there are many opportunities with this COVID, because you have to have this training, you have to have a learning for telemedicine, telehealth, you have to have setup. So there is compulsion, and there is compulsion for continuation as well. But there are challenges as well. Like we are unprepared. There are financial issues, and there are technical issues as well. We also could jointly publish one paper, translating policy to practice in telehealth, in Journal of Medical Internet Research. So previously, telemedicine was spoken a lot, it was advertised a lot, and even financed a lot, but it was used very little. Most of the part, the same body was left unused and just kept in a showcase. So we didn't know why this telemedicine pushed off. So now we are just focusing more because of the COVID. Now we are more used to, and people are also more aware about telehealth and telemedicine. So that is why now we are not only focusing on infrastructure, we're also talking about the human resource who are using it. We are also talking about the human factor to promote telemedicine. We are talking about training. We are talking about curriculum for all the healthcare training programs, formal or informal, even like undergraduate or postgraduate trainings, either in nursing or medical or paramedics. And also we should talk about reimbursement who are working in this field. So slowly this telehealth and telemedicine is growing up, and COVID also definitely has accelerated this process, and hope it will just continue even after COVID era, and telemedicine will pick up. Thank you.
Thank you very much, Dr. Udaya, and a very good presentation again. Any question from the audience with regards to the presentation from Nepal? Just a question, Dr. Udaya. You mentioned about the challenges of adaptation of the telemedicine in your country. In your estimate, how many % of the hospitals are really using telemedicine facility or the platform that you have just mentioned? Meaning, are they limited into one region or already being used all over Nepal?
Yes, only few, I should say. Like, because I mentioned this human factor, maybe because of the reimbursement, because of the policy, so it was not being used. Actually, we didn't have guideline. So in the COVID era, many private hospitals, they pushed government that we should have guidelines so that we can start telemedicine properly. So because of that push, this guideline was also published, and now all the government hospitals, they are planning to have a good setup with this clear policy for telemedicine. So till now, I think, if I have to guess, not more than 5% hospitals were using telemedicine before COVID, but maybe during COVID, many, even private hospitals, more than 60–70% hospitals were using that. Now it has decreased, of course, after COVID, but I think government hospital will continue this service.
Thank you, Dr. Udaya, and that's a good, description of the different types of how we per country really adopts, no, using telemedicine with the COVID. I think I have a question. There's a question from Dr. Satya. Go ahead, Satya.
Yes, sir. Thank you, Dr. Uday, and very nice presentation and very good experience, in fact. And I would like to know how the government support towards telemedicine in your part of country, sir. Because see, India, Bangladesh, Nepal, Bhutan, all these countries are now developing countries. So we need lot of support from the government. How it is happening in your country?
Yes, that is, I think, it's the same problem in India, Bangladesh, and because government, they don't see private hospitals as hospitals, even NGO hospitals, and there is always barrier for private hospitals or other hospitals to start up these services. They also don't form proper guideline or policy, but they also restrict others to use these. And I think India is also facing similar kind of problems. But now, because most of the patients, almost 80% of the patients are seen by private or NGO hospitals, only 20% patients are seen by government hospitals actually. But now, because of the insurance policy, because of the reference, referring the patients to these type of policies, now government are also compelled to start this telemedicine facility. And now they have almost made the guideline and this work plans. So I think it will boost up.
Okay.
All right. Thank you very much, Satya. Thank you very much, Dr. Daya. So I think if there's any other questions, I believe if there's none, our next presenter is Professor Akira, but unfortunately, he's not available. So I think we need to move on to our next session. So I'll be closing this session, and I'd like to thank all the presenters for a very nice presentation, and it was a good discussion. However, we want to, as Professor Shimizu has mentioned, I think we need to do more of to discuss more, especially new concepts now. And I believe based on the different experiences, the presentations from the different countries, maybe from there we can get these two ideas where we need to explore more of where telemedicine we will be discussing as well as tackling as well in the future. I think thank you very much, and I give back this session to Satya. Thank you, Satya, and congratulations.
Thank you, Dr. Jeffrey, for moderating this session very nicely. And as you said, it's very good interactions we had this session, and lot of knowledge sharing happened from different countries, and we learned a lot actually, in fact. And since we have another 5 minutes for the exciting live transmission from our institute, maybe you can have some other discussions. Kuriko-san is there?
Yes.
Maybe I think 5 minutes we can have some discussions. By that time we'll be ready with our live demonstration.
Yeah, actually, I wanted to discuss with Kuriko also and Professor Shimizu, as he mentioned a while ago with his last slide, that I think we need to discuss new things. So maybe we could ask Kuriko, any idea of what Professor Shimizu was trying to discuss a while ago?
So according to the Professor Shimizu's presentation, so it's a good chance to have the next year's plan in this ATS. But actually I don't have particular idea. Oh, yeah. But I can see Tomohiko Sensei.
Sensei.
Tomohiko Moriyama.
Professor Moriyama, can you expound more? Nice to meet you.
Good opportunity. Hi. Yeah, it's very good opportunity to have some discussion with our future plan. Actually, I don't have any special idea for that, but now the communication tool is moving to new stages, like an XR, extended reality, or metaverse or something like that. So I believe that kind of new communication system is quite useful to do some medical training. When we do some special procedure or quite a new procedure, the patient that should be suffered for some risk, kind of a medical risk. And sometimes there is a risk that we injure the patient during the medical procedure. So before doing that, and if there is some kind of an extended reality world or metaverse, we can train our technique on that virtual world. But of course, this kind of activity is quite advanced one, so I'm not sure we can make it within few years. But anyway, the one suggestion is a presentation by Dr. Sugimoto. Jeff invited in the last 2 years before at the APS. So this is one idea, and another idea is a kind of a teleconsultation. Now we do our telemedicine is mainly a webinar, I suppose. Of course, on endoscopy case discussion was made, but the webinar is the main contents of our telemedicine. But I suppose that we have a very good human network connecting in Asian countries. So I suppose that sometimes we suffer from very difficult cases. How to treat it and how to diagnose it. What is this diagnosis? So that at that time, we can get together like this and have some discussion among experts in each country. So I'm not sure what content is the best for us now, but anyway, I would like to conduct such kind of conference in the future. This is just my idea.
Yeah, it's very interesting.
Yeah, it was very interesting.
Yeah, it's a kind of new idea, but I also have some new ideas. But we also have, I think Dr. T.C. Chang is here. I'm pretty sure he also has very good ideas. Dr. Chang, Mr. Chang.
Yes. Hello. Good to see you.
Good to see you. So what do you think with regards to what are the new ideas we think we could tackle, as Professor Shimizu has mentioned a while ago?
Yeah. Well, from technical point of view, I definitely like to try all kinds of technology, new technology. And but I'll never forget, sometimes the first contact, a person in person is very important, and nothing can replace that. You know, just like we watch the Japanese sumo. Remember last time you missed the sumo? And I enjoy, actually, I be there and stay the whole day with watching the game. And I think that's quite different from I watch from TV. You see, because I was immersed in that kind of atmosphere. So I think in the future, how can we bring this, immerse experience? That's the future technology. I hope we can reach that. So that's why we meet, not only see you in this way, we can see you something around you and feel with you something, So I looking forward to that. And so before that can really come true, we still hope the pandemic can go away and we meet you in person. Thank you.
Yes, looking forward to that, TC Chang. Satya, back to you. Are we ready for the next session, Satya?
Yes, sir. We are ready,
okay.
And I think we can move on to the next session, which is live endoscopy. I request Professor Moriyama sir to take it forward, sir.
Okay, thank you, Satya. Okay, so we'd like to move to the next session, lab endoscopy workshop from AIG Hospital. As you may know, or you don't know, I'm not sure, but the AIG is, I suppose, the best hospital for this live transmission. As I mentioned in my opening remarks, they do this kind of live demonstration 24/7. It's really amazing, and they always accept any request of live demo from all over the world, I suppose. So then it's our great pleasure to watch what they are doing. And I ask all you guys how you can install this kind of live demo to your contents. So, okay, so would you show us your live demo, Satya?
Next one, huh?
Okay, started.
Yeah. Are we on, Satya?
Sir, 1 second, sir.
Okay, okay.
Audio.
On off చేసి. Hello, good morning and good afternoon, everyone. So myself, Dr. Rakesh. I am the medical gastro consultant from AIG Hospitals. With me, I have my team of support with anesthesia by Dr. Harnath and Dr. Srinivas. Then I have our chief technician, Mr. Srinivas, and his team. So I welcome you all, and it would be always a pleasure to be a part of this, which we did earlier also. So we just go into the case straight away. We have a young lady who has come with obstructive jaundice with altered LFT, and the suspicion is she must be having either a biliary stricture or a bile duct stone. So for that, what we are doing is we are doing a diagnostic investigation called endoscopic ultrasound, which we will do initially and see what exactly is there in the bile duct, and accordingly whether to do an ERCP to clear if there is a stone or to put in a stent if there is a stricture, we will decide. So I am using Olympus endoscopic ultrasound radial scope here, and I have my anesthesia team giving me the support of making the patient sleep with conscious sedation. And as you see here, I intubated the patient with my scope, and then I'm straight away going into the duodenum, post prepyloric area. I'll stand here. Now I switch on myself to the endoscopic ultrasound image mode, and then I'll try to see the CBD, which you can see on the screen. I'll point out with my pointer and show you what I'm looking after. If you can see my cursor, the green arrow, so this is the common bile duct of this patient. And here you have the portal vein and the common hepatic artery. So this is just to showcase to you that what we are dealing with and what I am looking upon. So as you see here, the red color is the vessel, the portal vein, the common hepatic artery, and the anechoic one is the bile duct. So my concentration will be on the bile duct to see whether any filling defect is there or not. So as you see here, I'll give you an enlarged view. So the upper part of the bile duct is anechoic. I'll freeze it and also measure the diameter of the common bile duct. So this is coming to around 4.5 millimeter. Now I'll trace it down and then see what's happening with the distal part of the CBD, that is the lower end of CBD. So as you see here, the lower end of CBD, I'll point out. So this is the upper end of CBD, mid CBD, and the lower end of CBD. A little amount of narrowing is there, but I don't find any obvious stricture anywhere or a stone as well. So that means that I am dealing with probably a bile duct where she had a gallbladder stones and one of the stone slipped into the common bile duct and then passed off. I'll freeze the picture and show you why I am so authentically saying. If you follow my cursor, this is the common bile duct, which is coming and ending at the papilla. This is the pancreatic duct. So this is what is called a stack sign. So I could trace the biliary duct right from the papilla up to the hilar area. And with this, I'm very sure that there is no obstruction or a filling defect in the CBD till the lower end. So in that way, in this particular scenario, probably doing an ERCP is not justified because one, I'm sure there is no filling defect or stone in the CBD. Second, her LFT you see from day one till now, it's coming to the normal levels. So that means there is a strong indication that the stone has passed off. So if at all you don't have this endoscopic ultrasound and you subject this patient for ERCP, then it is like a double-edged sword because one, she is a young female in 30s and the chance of post-ERCP pancreatitis is very high in this subset of population. Unless and until it's really indicated, you should never do because post-ERCP pancreatitis has got around 5 to 10% mortality, which is definitely not affordable in any scenario. So with this endoscopic ultrasound as a diagnostic method, I could at least save the time and money and also the complications what this lady would have had if I have taken her directly for a ERCP. So that's the advantage of having these multiple investigations and then carefully delineating what exactly you are doing it and then going forward. So with this picture, now we are very sure pretty much that CBD is normal and hence we don't attempt an ERCP. I just stay in the antrum of stomach and then try to see if I could see a gallbladder or some other pathology and then accordingly take the call. So let me also see the other parts of the biliary tract and come back. So now I'm just taking the scope out and staying at the G junction to see how the pancreas looks. As you see on the screen, the pancreas looks pretty much normal. A little bit of bulkiness is there, but otherwise nothing major contributing to this. So now I'll pull out the scope slowly, seeing the other structures. And the main purpose of looking at the bile duct is done. So now I'll end the procedure here. And I defer ERCP in this patient because there is no obvious indication. So that ends the procedure here. We'll also show you another case of chronic pancreatitis with pancreatic ductal caliculi. But in this room, I think we'll stop here. And if any questions are there, we'll be happy to.
Dr. Jeffrey has got a question, I think.
Yeah,
Jeffrey,
sure.
can you go ahead with your question?
Yeah, Professor, good afternoon, and very nice procedure. Just like to ask, sometimes patient presents with obstruction, but only secondary to a bile sludge.
Yes.
Will an EUS be good to visualize?
Yeah,
the
of
bile
course.
sludge?
Yes, very important question. And then EUS has a definite role even to pick up the sludge or microliths in the CBD. So that's the sensitivity and the best part of EUS. And that is where you actually can avoid these invasive procedures if you have a diagnostic modality like this. Because in this patient, MRCP was done actually, and that showed a distal CBD narrowing, but they didn't comment any filling defect in the bile duct. But as you see, the distal CBD narrowing, what was commented on MRCP also is misleading because we could see it on the endoscopic ultrasound that even that is a red herring, and that's the reason why we could trace the bile duct till the ampulla and showcase that there is no filling defect or any obstruction.
Okay, thank you. Can you also do a lithotripsy or EUS guided lithotripsy with that?
You mean to say for the bile duct stones?
Yes, for the CBD stones.
Yes. It's not EUS guided, but we have multiple ways of dealing with that. One is doing extracorporeal shockwave lithotripsy. Then we do the spile laser lithotripsy. And also the EHL, that is electrohydraulic lithotripsy. So all the CBD stones, most of them, if they are medium or small, we do these modalities and try to take it out endoscopically.
Okay, thank you very much.
Thank you. So we will move on to the next theater, and then we'll show a very interesting case of this chronic calcific pancreatitis, which I am sure very common in other Asian countries also. So, and we will demonstrate to you how we pulverize the pancreatic ductal stones without any surgery and kind of a minimally invasive, and then clear them. So we'll move on to the next theater. Just give me 2 minutes. I'll go to the next theater. Okay? Right.
Okay, thank you.
At very much, huh?
Okay, better to wait for 2 minutes or something.
I was impressed with the signal, Professor. Very nice.
Without break itself, we can move on to the other theater, but because of the time shortage, we planned only one case, one theater. We haven't planned for 2 theaters. So we requested Dr. Rakesh to move on to the second theater and show the procedure.
If the time permits, and for me, it's okay to watch the next procedure because I'm an endoscopist and so interested in their procedure.
Am I audible?
Sir.
Yeah. So I have come to the another theater, and again I was being followed by my anesthetist and my technician. Yeah. So that's the best part of having a team with multiple theaters is you can do these live transmissions seamlessly without any glitch anywhere, and then you can have continuous exchange of knowledge. So this case, as I told you, you can see on the screen there are multiple caliculi in the parenchyma of pancreas as well as in the pancreatic duct within the duct. So this patient, he's a young male who came with recurrent pain abdomen and found to have chronic calcific pancreatitis. So we have done lithotripsy on this patient using the extracorporeal shockwave lithotripsy. We have a machine which is one of its kind in Southeast Asia, which is a high-end Dornier Delta 3 machine, which takes hardly 1 or 2 sittings to pulverize any number of caliculi. And then once those stones are fragmented, we do this ERCP, flush out the fragments from the pancreatic duct, and then we put a stent to allow the free flow of pancreatic juice. So I'm starting this procedure. What I'm doing is in ERCP, I'm using a duodenoscope and the patient is anesthetized under conscious sedation. I'm passing the scope inside, going through the stomach and then entering the first part of duodenum beyond the pylorus and then the D2. So as you see here, I am in the stomach. We call it as a sun setting sign, where you see the papilla and then just slide into the first part of duodenum and then the second part. So now I'll shorten the scope as you see on the screen, and this is the papilla, which is the major papilla. So you see there is a little bulky papilla, but that's because of probably the recent lithotripsy what is being done. So now what I am doing is taking an accessory called cannulotome or sphincterotome. This is used to cannulate the ducts. It can be a biliary duct or a pancreatic duct. I am interested in this case to cannulate the pancreatic duct. So I'll stand in this position and then push my cannula with a guide wire which is already in. Srinivas has mounted. So I can see the papilla bulging and then I can see the papillary opening. So I'll push this cannulotome and then be in a position. As you see here, I'll try to adjust myself and then ask Srinivas to push the wire. And I'll push my cannulotome along with him. So he is manipulating his wire so that it will enter the pancreatic duct. You see, he is making his, so it's now gone into the CBD, but what I am interested in is the pancreatic duct. So please take out the wire, Srinivas, and then we'll be in the same position, but I'll rotate my cannulotome so that I'll push it a little bit and then Srinivas will manipulate. I can see here what Srinivas has done is he has put in the contrast and I can see the pancreatic duct is completely opacified. So now this will give me a pathway of where exactly he has to push the wire and along with him my cannulotome. So now that the wire is deep inside and cannulotome is in position, I'll make a cut. This is called a sphincterotomy. That means I have entered the papillary orifice and then the pancreatic duct. Now I am going to do sphincterotomy, that is cut open this papilla so that one, there will be free flow of the fragmented stones, and second, my accessories will be easy to pass in so that probably I can put a stent if required. So now I have done a small cut and I'll try to negotiate my sphincterotome. Let me cut a little more. So this cutting is done with a cautery or a setting which has got a machine called RB machine, which is used to cut this. So because of multiple caliculi obstructing my way, can you flex it a little? Okay. So this is the major papilla which I am cutting. So it's called major papilla sphincterotomy. So sometimes we also target the minor papilla because pancreatic duct is originated from two sides, two ends. Okay. So now you see Srinivas has put in the wire deep inside the pancreatic duct and I am following it by railroading my cannulotome on the wire. You can see I have gone deep inside into the pancreatic duct up to the mid body. Now he will exchange the wire which was there already. It's a smooth wire called the thermo wire. It's very smooth. So usually after you cannulate and go deep in, that wire will be exchanged with a stiff wire which he is using now. And the advantage of this wire being there is you can manipulate the things, you can put in a stent and you will have a hold on the whole anatomy. Yeah, so now as you see here, the wire is deep inside. I'll extend my cut a little bit so that all the stones which are there inside, which are fragmented, will come out easily. Okay, I'm okay with that. So now I'll take out my cannulotome and then I'm going to put in a stent. It's called a pancreatic duct stent. It's a plastic stent. So that stent will remain in the pancreatic duct for at least 3 to 6 months. In this meantime, all the stones which are fragmented will be flushed out, and also at the same time the pancreatic juice will flow freely, so that the patient will be completely free from the pain episodes what he is getting all these years. So you see, this is a stent which I am going to put it inside the pancreatic duct. I am pushing in. You can see now the stent coming out on the endoscopy screen. So this stent, using the fluoro, I'll put it deep inside the pancreatic duct. Probably it will go up to the tail of the pancreas. And once there is a radio-opaque mark here, which you can see shortly. So I'll go till that mark, and then Srinivas will pull the wire out and I'll push the stent inside so that it will stay there. You see here, you can see now on the X-ray as well as on the endoscopy screen. This finishes the procedure, and then the patient will be back to his conscious in half an hour or so, and he'll stay for a day till the late evening as a daycare procedure, and he'll go back home.
Okay, thank you. Thank you for showing us a very wonderful technique and detailed explanation. I suppose that most of the participants understand what you do and what you think during the procedure. Thank you so much.
Thank you. Thank you very much.
Okay, then let's go to the short presentation from Satya about the live demo in your institute.
Yes, sir. Thank you very much, and thanks, Dr. Rakesh, for the wonderful presentation, demonstration of 2 cases where he could able to show us the pancreatic anatomy and the advantage of UES. So, after looking at the live transmission, I wanted to explain how we do these live transmissions. If I can have my slide. So this is what I am going to present behind the scenes. Generally it happens in movies, but in live workshops also there is something happening behind. So we will see during live how we are going to organize this live transmission to our institute to other places. So this is how one of our doctors is doing the live procedure using the Olympus endoscopy, upper GI endoscopy, and this is our endoscopy room system. And when doctor is doing, generally we'll have a monitor where the doctor can see the endoscopy image and the fluoroscopy image and the video what we are transmitting outside, because the performer is always keen to see what we are transmitting outside, otherwise they can't move ahead with the procedure. So we'll give a written video from our studio room what we are transmitting to the doctor. We have a look onto that. When that endoscopy is connected to the processor output is taken, and this is connected on the same tower where we have the endoscopy, because all our cables are interconnected in the theater. So endoscopy is connected here, our external camera is connected here, and the fluoroscopy equipment is connected here. And the same way we have the audio. We can see these audio, those 2 connectors are audio connectors, where we have 3 receivers, cordless receivers in the theater. These 3 audio systems are connected to the same tower, where we have the video and audio, the same tower. So this is the rack which is located on the back side of each OT. Each OT have a dirty corridor on the back side, and the same place we have the rack connected for each OT complex. So all the videos from the endoscopy room or the operation theater comes to this rack, and connected here, including the audio. So from here, all the signals, if you see the distance from the OT to the rack where we are connecting these cables is around 15 meters. And from this rack, again we have a main console in our transmission studio, which is almost 130 meters distance from the rack. So these two racks are connected using only the fiber optic cables. You can see the yellow cables, those are all fiber optic cables. So all the signals from all the 19 theaters are connected to this, the main rack in our transmission room. So again, after this, what happens, this is how the rack in the OT, each OT. So all the signals comes in, and that is designed in such a way that takes all the inputs, and rack we are transmitting, connecting it to the main rack in the transmission room. I will just make it bigger way. So this is the main rack in our transmission room, which has got around 28 inputs, 128 inputs at a time this can take. All the theaters, almost 19 theaters are connected to this, including the open theaters, laparoscopy theaters and endoscopy theaters. So from this rack, again we will take the output here. This is what we see externally. This is all happening on the back of the screen, and this is where we get all the outputs here. And sitting here, we will control which room has to be transmitted, which OT has to be connected, audio to be connected. This we have two smart systems there. This is the one system which we use for controlling the video system, theaters and the format, what format it has to go, which theater to be connected. And the next small one is the audio system. So using this, we can switch on or switch off the mics and the speakers in the specific theater. So when the theater is not in operation, what they should know what discussion is happening. So we keep the speakers on in that theater and mute the mics the specific theater. If I enlarge these images, and from this video system, the output, final output is above my head. This is the system what we see, what we are transmitting outside. So this is going to be transmitted, connected to the Zoom system or the Polycom system. If you see closely, the top left one is the video console, where you can see ERCP1, ERCP2, US1. These are the different theaters. We just click on that each particular theater, so that theater is connected. This is, if we enlarge, you can see that ERCP1 and ERCP2, these are the theaters, and we click onto that. Next we go to the format. If you want to show only the external camera, we only press that external camera. The fluoroscopy, just click on that, the gets automatically, and the same will be transmitted. And this is the audio console system, where suppose if you see Endo Studio, that is our transmission room, we keep on the speaker on and the mic is on mute when we are not talking. And if you see the Endo room, the speaker is also on mute and the mic is also mute. So it's only touch, just touch on the switch on mic and we can switch it on. We switch off the speaker, we can switch off the speaker. So this is how on the behind we operate the scene. This is what the final output we see on the screen when we are transmitting. So we can, all the systems are HD configured. We get, every system delivers high definition video, and the audio quality is also good. Maybe we already watched on this during this live transmission. Thank you very much. Any questions? Maybe I am ready to take it up.
Hey, I have a question. Okay, can I?
Yes, sir.
Hey, during this kind of live demo, especially in the ERCP or US or something, the switching the camera is needed, like an endoscopic images to ultrasonographic image, then the fluoroscopy image, and going back to endoscopy or something like that. So I suppose that this kind of, who take care of this kind of switching?
Yeah.
Doctor do or you do?
Yeah, it's a very good question, sir, actually, because you need to know what to be shown live, the fluoroscopy importance or endoscopy. So working for so many years, we know in gastroenterology which is important now to be telecast. So myself and Mohan will take care of this part. We select the video, which one to be shown and which one to be not to shown.
For doctors, that should be very comfortable. Usually, doctors should announce it to the engineer in our usual endoscopic live.
Yes, sir. We are now more familiar with all endoscopy procedures. When to switch on to fluoroscopy. Now the entire live is operated by Mohan. Mohan is in different studio because we had one live workshop in the morning, one ENT procedure to Singapore. So Mohan was busy there. That's why you could not see Mohan in the morning. So he was in the OT transmission room. You must have noticed on the back of him, you can see a lot of OT images. So now after finishing that, he joined endoscopy live. So we only switch over all this.
Okay, is there any questions from engineering side or something?
Yes, yes, may I have a question? I noticed two of your operating room, the color of the room, which is a little bit more blue than usually. Is there any reason why your operating room from the room camera shows the screen, shows your imaging is more blue than other? So any reason?
Yes, yes, sir. Like suppose, particularly in endosonography, the images are black and white. So if the room light is very bright and white in color, so you can't have a clear view on the monitor of the endosonography. So if the room color is in blue, the view for the doctors who are performing the procedure can have a very good view of the endosonography. So there are very minute things doctor need to notice while doing the procedure without spending a lot of time. So that's why we make the room dark with a blue color.
Thank you. That's very important. Great lesson learned from you. Thank you.
Thank you, Chiang, sir.
Rico?
Yeah, thank you very much for your wonderful demonstration and explanation, and really informative. And I have a question. Do you control the camera, pan and tilt and zoom in the operation room or demonstration room, or you do remotely, or you fix the camera?
No, the camera is operated manually. The cameraman will be there because if you try to operate remote, in fact we have a room camera fixed on the in each theater. So operating remotely won't give the sharp vision for us. Mohan is.
Yeah,
there are many cameras are available in the market. It's a joystick operation. But the problem with the distance, here this 130 meters distance. So if operating everything is very tough. Actually, we tried all fiber because of that the distance issue.
You can't have sharp movements there. So that's why manually we operate that. So zoom in, zoom out, everything is possible.
Yeah, that is very important, and cameraman need to understand the local atmosphere. So you have good cameraman and some staff, not only one, but some staff you have.
Yeah, it's entirely our team. Our academic cell takes care of all that. All our team, even sometimes even I operate the camera, Mohan operates. All my staff, they can operate cameras.
Okay, thank you.
Okay, any other questions or comments? Nothing? Okay, then let's move to the next session, session 5. Okay, by Tansang and Arya. Right?
Okay, thank you. Now our next session, I will join the host with Arya. Is Arya in? No, I don't see.
No, not yet.
Okay. Oh, in that case, let's keep track of time. Let's continue. The title of this session is called Indian Telemedicine Workshop Research Projects, and our first speaker is Miss Akaranja Bansal. Forgive me for wrong spelling. and he's going to talk about institution of liver and biliary science. Here is the floor is yours, Miss. She's there? I think she's.
Yes. Hi. Yeah.
Okay. Thank
Good
you.
afternoon, everyone. Yeah. Am I audible?
Yeah, your voice very clear.
All right. So I'll be just sharing my screen.
Miss Akansha, we can't hear you, and your screen seems still black.
She's trying to share her presentation, locating the presentation.
Some technical issue. There she is. She's connecting again, and just wait for her.
Am I audible? I'm sorry for the disturbance.
Okay, please go ahead.
Just give me a second. Dr. Satya, just give me a minute. There is some internet connectivity issue.
No
Just give.
problem. Shall we move ahead with Dr. Sheila Jan's presentation and come back to you?
Yes, you can proceed with Sheila John's presentation. I'll take it after that.
Thank you, Ms. Akansha.
Okay.
Yang sir, please.
Okay. We are, well, it's okay. You can carry on for your technical problem solving. So maybe, shall we move to the, since we see our old friends, Dr. Sheila, and
sure.
Yeah, so we like to invite you to, the floor is yours. Please go ahead.
Yeah, I'll share my presentation. Good afternoon to everyone. I would thank the organizers for giving me this opportunity. Thank you very much. My topic is Shankar Nethralaya Teleophthalmology Project. I'm from Shankar Nethralaya, Chennai. I would like to talk about, I have no financial disclosures to make. Now, blindness in India is 36 million blind in the world, 15 to 18 million blind in India, 75 to 80% the blindness is avoidable. Now, primary care services in rural India is by trained manpower and the state-of-the-art ophthalmic infrastructure. Now, healthcare availability in India, if you see, 80% of the population resides in rural areas, and 70% of the healthcare resources are in urban areas. And the shortfall of doctors, especially ophthalmologists. It is 1:1 lakh population. Now, if you see the telemedicine establishment in India, it was done by the Indian Space Organization. They started in 2000, 2001-2. They established telemedicine network coverage in various states and tribal regions and implemented telemedicine in India. For us, Indian Space Organization helped us to establish between 2 fixed centers in 2002. And in 2003, they helped us with a mobile van, and they fixed the VSAT facility on the top of the bus. You can see the VSAT facility there, which is connected to the satellite in space. Now, this van consists of 3 compartments. The first compartment is where the driver and the team members sit. The second compartment, where the examination of the patient is done. Third compartment houses the other stuff, equipment which has to be carried. Here you can see the examination being done. It is a single room where the examination, each patient is brought in and the optometrist examines, does all the procedures. The video conferencing equipment is also kept here. So once the patient finishes the examination, he is connected by video conferencing, that is through satellite, with the help of the satellite connectivity, to the base hospital. The doctor advises the patient what treatment, what thing to be done. This started in 2003 and went on to 2010 level. By 2011, internet had penetrated the villages. So we switched to internet connectivity because we can go in for a smaller van which can travel the narrow routes. Now this bus did not have an examination room. What we did is it carried the tele-team members, the state-of-art equipment, and a generator. Now here, the internet connectivity was enabled through a laptop via data card, 2 Mbps internet speed. The persons who were there the mobile units were optometrists, social workers, the driver, the optician, project officer, and the fundus fitter. That is mainly paramedical staff. The ophthalmologist did not run. And at the main hospital, we had a central hub. There's a technical coordinator, information and technology assistant, assigned ophthalmologist. Now, we also had a mobile refraction van, which was given to us by ACR India. This also had 3 compartments. The first compartment where the driver and the optician travel. The second compartment had a delta edger, where the edging of the spectacles could be done, and ready-made spectacles were handed over to the patient at the time. The third part had the lenses and frames. Now, spectacle dispensing can be done at the remote villages where there were no optical shops, and ready-made glasses were given to the needy patients within an hour. But here again, very high powers like myopia, hyperopia, or astigmatism could not be done. That had to be done at the base hospital and distributed later. Now, if you see the workflow at the campsite, we had an electronic medical records, and the patient's demographic details like age, sex, address was incorporated. Then visual acuity was checked for the patient. Again, the anterior segment was checked with a slit lamp, intraocular pressure was recorded. Then fundus examination was done. Non-mydriatic fundus photography was done. That is, physiological dilatation was done for the patient, no drops were applied. And then non-mydriatic fundus photography. This was very helpful in all systemic diseases, especially for diabetes, where diabetic retinopathy is a blinding disease. We also had an optical shop where the frames were carried and patients can choose their frames. Most of the spectacles were given through donations. Very rarely the patient had to pay. Lower you see again the central hub where the ophthalmologist is sitting and giving the advice. Then you have a nurse who examines the BP and other things. And awareness programs on various eye diseases are also conducted. This is the one EMR chart with comprehensive eye examination where the history, findings, plus whatever the fundus photograph and anterior segment photograph we have taken are uploaded. Now the virtual visit at a campsite is with a data card with 2 Mbps internet speed in the rural villages. The internet speed is only 320 to 650 kbps. Software supports video conferencing at bandwidth of 512. Now, real-time sharing of images was done at the base hospital. From the campsite, the EMR was there, fundus pictures were there, anterior segment pictures were there. The ophthalmologist was able to discuss with the optometrist and the patient and advise the patient as well as the attendant. Now, in Tamil Nadu, we have conducted more than 3,000 camps, and patients seen were more than 270,000. Spectacles have been issued, teleconsultations were done. But here again, in very, very remote areas, teleconsultation was not feasible because we did not have the towers supported us. And in remote areas, the bandwidth was very low and did not support video conferencing. In those cases, we brought the patient to the base hospital and examined the patient. Now, prevalence of ocular diseases, you see, majority were refractive errors. So that is why we had that refraction man where we could do the glasses, hand over to the patient immediately at the campsite. Second was cataract. These patients were brought to the hospital and surgery was done free of cost. The other cases were retinal diseases, diabetic retinopathy, and other diseases. All these cases were taken to the base hospital, further investigations were done, and treatment was also done. Now, this is before COVID. During the COVID time, the teleophthalmology camps could be conducted only with government permission. So we started in March 2021 and we continued to September 2021. 2 months, May and June, we could not conduct it because due to lack of government permission. And all the COVID protocols were followed in the camps. Social distancing, hand washing, hand sanitization. I'd like to share a video with you.
Due to the COVID-19 pandemic, the eye camp activities have been restructured since March 2020 as per the Government of India guidelines. The COVID-19 protocols are strictly maintained in every camp in both rural and urban areas. One such camp was organized in the rural areas in Periyavayavur, Kanjipuram district on 7th of August 2021. A middle school was chosen as the campsite after obtaining necessary approval from the local bodies. Our hospital staff went to the campsite along with the instruments, and necessary examination stations were organized. Patients at the campsite were required to wear a mask and to follow strict COVID-19 protocol. Patients are instructed to use hand sanitizer using an alcohol-based hand rub for 20 minutes and are seated in the patient's waiting area after ensuring adequate social distancing between patients. The patient's temperature is then checked and noted in the patient's identity card and are registered electronically in the EMR system along with the name, age, and address and other demographic details. The optometrist then performs autorefractometer after wearing a mask and a face shield and after using a hand sanitizer. This is then followed by a detailed history taking after ensuring sufficient social distancing is maintained. The optometrist then tests the distance visual acuity after disinfecting the trial spring occluder or by asking the patient to close one eye after using hand sanitizer. The near vision chart is held by the optometrist instead of the patient after hand sanitization. Patients who cannot read charts and languages are tested using the Electrophysiology e-chart. This is then followed by pupillary examination and examination of extraocular muscle movement. Patient's spectacle power is then examined using a lensometer, and the details are entered in the electronic medical record system. For the spectrum examination, the patient's chin red and the forehead rest are cleaned, and the optometrist wearing a mask and a face shield, and the patient undergoes ocular examination. In case of any systemic diseases, The patients undergo undilated photography, and in the presence of any abnormal retinal findings, the patients are referred to the base hospital for further evaluation. Social distancing is maintained with only 5 patients in a room at a time. The teleconsultation is arranged between the patient, the optometrist at the campsite, with the teleophthalmologist at the base hospital. Patient's findings are then shared with the ophthalmologist through the electronic medical records, and the patient's consultation is improved with a real-time consultation with the ophthalmologist. The ophthalmologist examines the slit lamp and other photographs and provides further advice to the patients. The patients are then referred to counseling. Once the patient has been diagnosed with cataract or other ocular complications, the camp coordinators or counselors provide referral and give clear instructions for patients. For patients requiring only a change in glasses, they are referred to the optical shop where their interpupillary measurement is taken. The patient is then presented with a choice of frames. Once finalized, the glasses are made and dispensed later at the village for the help of donations. So this is a summary of the camp statistics shown here. This camp examined 70 patients. A majority of patients had refractive error and were advised to spectacles based on the visual needs and requirements.
You see the results, we conducted 57 camps were conducted and more than 5,000 patients underwent comprehensive examination and 159 teleconsultations. Here again, if you see the refractive errors at the maximum, followed by cataract, then the retinal diseases, then diabetic retinopathy, then other diseases come. And all the patients for refractive error, they were provided glasses free of cost. And the other patients who required further treatment and who were taken to the base hospital for the investigations were done and treatment with a medical or surgical were provided. This mobile van has helped us both before COVID and after COVID, and this model we have been following for the rural patients. As Professor Vikram Sarabhai has said, we must be second to none in the application of advanced technologies to the real problems of management. Thank you very much. I once again thank the organizers for giving me this. Any questions?
Thank you very much. Any question for Dr. Sharia? John? Yeah. Hi. I was very surprising to know that almost half of the world's blind people population is in India. So I think your team did a great job. And I'm curious, do you have any like a cornea transplantation program for blind people? Because sometimes they can be their eyes can be seen by do some transplantation. Do you do much in India?
Corneal transplantation, you're asking? Yeah, cornea, we have a very good cornea department. And there are many surgeons there who do corneal transplant. Depending if the patient has corneal opacity or something, they're brought to the base hospital. And once again, we have to depend on the donor. We have to get the donor eyes to do the corneal transplant. That, of course, is done.
Is the donors enough? I mean, in India, some countries, they lack of the donor. So how about India?
Donors are there now. It is more and more we are creating awareness after that they should donate their eyes. Is awareness we are creating among the public. And of course, all eyes cannot be taken. There are some diseases where the eyes cannot be used. And all said and done, younger eyes are much better than the very old people who die. Their eyes given. So depending on that, the donor will get the cornea.
Gotcha. Thank you very much. So any more questions? Okay.
Ms. Akanksha is ready, I think. Maybe.
Pardon?
Yes, and I apologize for the previous inconvenience. So good afternoon, everyone, and I'll just share my presentation.
Audio.
Okay, now we can see your presentation. You can make a full screen.
Yeah, I'm just doing that. Is it visible?
Not full screen. It's in your editing mode. Can you make a full screen?
No, it's in full screen only.
You already see the full screen, but we only see the editing mode. Okay, now it's coming. Thank you very much.
Yes.
Yes.
So I thank the organizers for giving me this opportunity to showcase our work on such a prestigious platform. So today I'll be talking about our experience in running telementoring training programs at ILBS. So I have no disclosures to make, and there is no conflict of interest. Before I start my presentation, I would like to share that we have trained 11,500 healthcare workers through telementoring initiatives at ILBS. So why are we doing it? Because there is barrier to specialist healthcare in the country, and as we know that in tier 2 and tier 3 cities, especially there is lack of infrastructure, specialist treatment is not available. So there is a greater need to implement such programs. The basic difference between telemedicine and telementoring is telemedicine is basically providing medical care to patients through telecommunication. Telementoring is transferring of specialist knowledge and experience to other providers through telecommunication technology. What we are doing at ILBS is we are running a telementoring program wherein we are building capacity of general physicians and nurses across India. So the purpose of our program is to further knowledge and skills of healthcare workers in liver diseases and to promote consistency in patient care with greater efficiency so that we can reduce disparities in liver disease treatment. I'll be now talking about our project Extension for Community Healthcare Outcomes. We are running this program since 2016. The program is run through use of telemedicine infrastructure. So we are the Hub Institute, and these are all the medical colleges who join us for the training programs at ILBS. We run synchronous sessions, and so that these doctors. The 4 pillars of our program is we engage healthcare workers so that they can acquire new skills, update their knowledge, and enhance their competencies. We educate them and make them self-sufficient in treating liver disease patients through case-based learning and co-management of liver diseases. We enable them in better identification of diseases which were earlier left unidentified. And we are upscaling the healthcare infrastructure at grassroots level. We are empowering the community by reaching the unreached, by providing treatment at the doorsteps of the patients. So our reach with our aim of moving knowledge, not people, we have been successful in implementing this program in 26 states across the country, especially in tier 2 and tier 3 medical institutions. And we have trained more than 8,000 healthcare workers, including doctors and nurses from 400 medical institutions. So the method that we use is we have a dedicated project management team who's looking after the program. We have a dedicated speakers and faculty from Department of Hepatology, Pediatric Hepatology. In some cases, we do have speakers from other medical institutions as well. And we have a dedicated healthcare IT team also to provide basic infrastructure support to the attending participants. So we run 2 kind of courses for doctors and for nurses. We generally encourage residents and faculty from internal medicine department to attend the program from again 2 and 3 tier cities without the Department of Hepat and Gastro in their institutes. And for the nursing program, we encourage all students and faculty in nursing colleges across the country to attend the training. So we basically use teaching learning technique. We have lectures, synchronous live sessions that are being taken by the expert faculty. It's a two-way session that is being conducted. We also have asynchronous sessions. Whatever sessions are conducted are being recorded and are uploaded on our website so that later participants can use it as a ready reference material. We also conduct contact programs, and we also conduct pre-training and post-training assessments. So this is the curriculum that we have for the doctor's training program. We have about 30 topics in this, divided into 8 modules. It's a 6-month training program. We initiated this in 2016, which is still ongoing. We keep on revising the curriculum on the basis of feedback that we receive from the participants. And till date, we have enrolled more than 1,000 doctors in this, and we have conducted over 200 online classes, and we have covered more than 200 medical colleges across the country. This is the curriculum for the nursing program on liver diseases. It is a one-day training program, and we have trained more than 6,000 nursing students and faculty in this program. During COVID, we have initiated another training program for nursing professionals, Empowering Corona Warriors. It was a 2-week-long activity, 2-week-long online program. Again, it was all our sessions are very interactive, and more than 1,500 nurses across the country has joined this program, and the program was also accredited with 24 credit hours from Delhi Nursing Council. These are some of the screenshots of our sessions. In all our trainings, we ensure to conduct pre and post training analysis to check whether whatever is being taught is being adapted by the audiences or not. Here you can see that there is a significant improvement in participants' knowledge, slight improvement in their attitude and practice. You can see a good amount of upgradation in the mean and median of participants' knowledge after attending the training program. We also conduct an impact assessment study. We did this one on hepatitis B vaccination status. How many people were vaccinated before training, not vaccinated before training? How many were vaccinated after attending training and still not vaccinated? Another study that we conducted is a change in clinical practice of nurses after attending training program. So if you can see, almost 80% of nurses have started following best practices after attending the training program that we have been conducting. They are following universal protection, universal precautions, personal protective use of PPE. Then they are advising their patients to go for testing and vaccination. We also can take online feedback from all the participants after the class, so to ensure whether the training programs are going in the right direction or not. And in case we receive any feedback that is beneficial, we try to implement in the future trainings. These are some of the screenshots, the participants' feedback that they have shared with us, their experiences. We also conduct contact program for doctors at ILBS once a year, and the purpose of conducting this contact program is to give them exposure to the premier institute like ILBS, so that they can see how things have been done here, and tomorrow if they want to implement any of it at their own hospital, it will be of benefit to them. We give them exposure to hemodynamic lab, endoscopy procedures, fibroscan procedures, virology lab, all these things, and some lectures also by the expert. We have a dedicated website of the project, which has all the detail about the program, what all activities we are doing. It has the archive of all the sessions that we have conducted since 2016, which can be used by participants as a ready reference material. We have also conducted a skill development program for telemedicine engineers and doctors and engineers who are managing telemedicine setup at their institute. We did a one-day workshop for them. It was attended by more than 115 participants across 70 institutes, and world-renowned experts in the field of telemedicine were invited as guest speakers. So what are our strengths? We have excellent network of colleges and institutions. We have a dedicated project management team. We have expert speakers from ILBS and some from the other institute as well. We have state-of-the-art web-based video conferencing equipment. We have user-friendly interface for learning. We have excellent monitoring and evaluation system in place, and we collect participants' feedback. So what are the challenges that we face? Often we have observed that because this is an online program, reception is low. Participants, they tend to, get disoriented in between the sessions. So it's very important to keep the session interactive. Slides should be of a smaller duration. It should be interactive. So we try to keep quiz contests. We try to use videos as much as possible, tutorials. Even after so many things that are happening online, people are lacking basic virtual etiquettes. So at the beginning of the program, we take a session on do's and don'ts in a virtual classroom so that they understand that what is expected out of them during the training of the next 2-3 days. Most of the participants, they're interested in getting certificates only. You will see that majority of the participants, their camera is not connected and you don't know whether they're listening to the session or not. So in all our sessions, we have a backend team and we ensure that participants are sitting and attending the session and they're not roaming here and there doing some other activity. And generally, we do often face connectivity issues, as I also did at the beginning of my session. Moving forward, we want to expand our network of colleges to ESIC medical colleges across the country. We want to take feedback to another level and we want to do in-depth interviews with our participants. We also want to do an impact assessment study at the medical colleges to see whether there has been increase in hospital admissions in such liver disease patients and how confident these doctors are in treating patients now, and whether patients who were earlier were not referred on time, is there an improvement in referrals or not. We also wanted to have a dedicated tutor support for our recorded video sessions, and we want to introduce newer courses for various other specialties also, and we also want to promote e-learning as an effective mode of education. These are some of the publications that we have done over the years under Project ECO. In case anyone of you is interested in knowing in detail about how we have done it, how our trainings we have conducted, what is the result, everything. So some of the other initiatives that we are doing online through virtual training only is COVID-19 and viral hepatitis. And there's one more initiative on alcohol-related liver diseases. So these training programs also are attended by doctors and nurses, and over 5,000 healthcare workers have already attended these two trainings. So it is important to monitor and evaluate training programs, especially in e-learning setting, so that we can ensure that participants understand and enhance their skills for which the program has been initiated. Thank you.
Thank you very much. So any question? Doctor?
I have a question for her.
Yeah, please.
You said one-day workshop was done for telemedicine. So what sort of, is it more IT oriented, or because you have the doctors from all specialities, you know, attending it? So it can be specialty oriented.
Yeah, so ma'am, medicine workshop actually if you see that telemedicine setup at few centers are being managed by the healthcare workers themselves. In few centers, you will see that they have IT people who are handling it, but at some centers, it's the doctors or the nurses who are managing it themselves. So it was a common platform for both of those to understand what are the latest technologies, how you can better utilize your resources, whatever you have available with us. So it was a co-learning for anybody and everybody who is into telemedicine. Telemetry program.
That is the various softwares and the hardware.
Yes, softwares, hardwares, then whatever resources you have available, how you can use it, how to do a live endoscopy sessions, all these things were covered during the entire day.
Okay, thank you. Okay, due to time constraint, we would like to move to the next speaker. And in the meantime, our co-host, Dr. Ari Karaling, he's joined. So Dr. Arya, please.
Thank you, Mr. T. So the next presenter will be Dr. Hardik Ruhwani. Yeah. He's a consultant gastroenterologist from the AIG Hospital in Hyderabad. So he also has a vast experience in performing endoscopy, colonoscopy, and has other publication. And I think with his experience, he will present a very exciting experience in conducting telemedicine in AIG Hospital. Dr. Hardik, are you ready?
Yes, I'm ready.
Okay, please proceed.
Yes. So very good afternoon, and thank you very much to the Asia Telemedicine Committee for giving me the opportunity to share my knowledge on artificial intelligence. So my talk will be on artificial intelligence in gastroenterology. So first of all, I'll have some disclosures. Like, we are in a project with Satisfy Health in Canada. The AI for GI project is going on for IBD. With the Japanese government, we have an Indo-Japanese project for AI in GI. And most importantly, I want to tell that our knowledge on AI is still evolving, and we will like to share our knowledge. So my talk will be mainly on the objectives. My objectives for the talk will be, first we'll discuss on AI in general, our current knowledge on AI, and then I will speak about the future in AI, the artificial intelligence in gastroenterology. So let's first simplify what is AI. So as we can see, AI is defined as computer systems or algorithms that can perform tasks which normally require human intelligence, like visual perception, speech recognition, and decision making. So the most easiest form to understand is the mobile phone. The smartphone that we use has many applications that are based on AI. And the next is the Tesla car. That is another nice symbol of the machine that is working on artificial intelligence. Another simple example is Facebook. When we upload our photos, it automatically highlights the faces of our friends and tags it. This is through the AI algorithm. So how we define artificial intelligence is based on the three terminologies that are most commonly used. The artificial intelligence is the first primary thing that started in 1950s and 1960s, when computers were coming in, were being developed. So it's an advanced mathematical process of computer-mediated designing of algorithms and models to augment, recreate, and support the normal human intelligence. Then came the machine learning in the late 90s. And this is the type of computer-based predictions through various mathematical algorithms through the provided data, and it can provide predictions for further assessment. Then came the concept of deep learning when further development occurred in the 2011 and 2012. It's an advanced and complex form of machine learning that uses multiple algorithms arranged in various complex neural networks. So what are neural networks? As we can see, through various inputs like the imaging, endoscopic imaging, CT imaging, pathological imaging, to genetic imaging, the data gets analyzed through various processes, through various computer algorithms, and then there is a final output, the examples of which we will see in the next slides. So looking at the gastroenterology part, the major focus is basically on endoscopy, because as we can see, the endoscopy, we have developed many new endoscopes, new imaging modalities, but still there are certain things which are missed on diagnosis. So as we can see, the doctors need help with real-time cancer detection and diagnosis. The human eye is not accurate enough, but then we need the help of machines to help us for proper diagnosis. So what it looks like for an average gastroenterologist, if we put in the AI algorithms, as we can see, studies have shown that the 40 times better diagnosis and faster diagnosis can be picked up if we apply AI algorithms. So what are the applications of AI in endoscopy? One is the colonic polyps, Barrett's esophagus, early gastric cancers, and next is the evolving part of IBD, on which AIG is working in future. So as we can see, the computer-aided polyp detection is a very well-known and well-accepted fact that there are various applications. As we can see in the video, sometimes in a human eye can miss the polyps, but if we look clearly, the AI will pick up the polyps and it will earmark where the polyp is. When we go inside and the depth and see, then we can see that there is a polyp here which can be removed. So that helps in the diagnosis. So as we can see here, the software will pick up the polyps. It will be analyzed through various processes, and final outcome will be the classification of polyps. So this is through the Olympus scopes that we use. There is a software that they have been made. Special endoscopes have been made. So we can detect the polyps and also characterize them. And accordingly, if they are neoplastic, we can go in for further management easily. So there are various softwares available. As you can see, Fujinon CAD I software is available. Olympus Endo 8 is available. Discovery through Pentex and Medtronic's GI Genius is available. These are all for polyps. Various studies have shown that based on the artificial intelligence softwares, we can have a better adenoma detection rate and also polyp detection rate. Also, there is a study which is published in GI endoscopy that has shown that in polyps less than 5 mm size, we can directly remove them and we can discard them. That plays an important role so that it reduces the healthcare burden, and we can directly manage the patient, telling them that the polyps are non-neoplastic, so we have removed them. Next application is the Barrett's esophagus and the esophageal cancer. Barrett's esophagus is a condition in which there is alteration in the mucosa of the esophagus. It is a pre-malignant condition leading to esophageal cancer. So if we early diagnose it, then it prevents development into esophageal cancer and improves the management in general. As we can see, there has been development of AI softwares where we can pick up the hot spot or the soft spot where we can take the biopsy, and it increases the chances of diagnosis of cancer. So the study has proven, the Argos project that was done in Europe, it's a multi-center study that based on the various algorithms, the software picks up the spot where we can very nicely we can judge where we should take the biopsy from, so that it increases the chances of diagnosis. As we can see, Barrett's esophagus, the most important thing is the pathology. If we get a good pathological diagnosis, we can tell the patient to be on follow-up, and we can treat the patient early. As a result, AI plays a very important role in early diagnosis of Barrett's esophagus and hence prevention of adenocarcinoma. Next is the application of detection of early gastric cancers. Studies have proven that, as we can see, a study by Wu et al., we can pick up early gastric cancers based on AI algorithms and hence treat the cancers in an earlier stage. Next is, most important, is the inflammatory bowel disease. Is an evolving thing. How does AI help in IBD? It helps in the diagnosis, prognosis, treatment selection, treatment response. We can monitor the disease, we can deliver a proper care, and hence new drugs development can be taken care of. As we can see, the Mayo endoscopic scoring system is there, which we use usually for colonoscopic grading of the ulcerative colitis, which can be normal, mild, moderate, or severe. This is known as, based on that, we have made an algorithm. There are Mayo scorings available. Now, AIG is working on this AI platform where we have recorded multiple videos along with Satisfy Healthcare, and based on the various color coding, we are going to categorize the patients on the Mayo score, and hence we will make a software that can help in the telling about whether the patient is having mild disease, moderate disease, or severe disease. Based on that, we can give them proper treatment. As we can see, there is a color coding here, gray, and red means that there's an active disease. Blue means that's a biopsy that has been taken, and hence the scoring will be given based on that. So there are various other AI-related applications, like in Crohn's disease. There are radiological CT scan guided softwares available which help in the diagnosis. Next application of AI in IBD is drug discovery. If we can know whether the disease is mild, moderate, or severe, it can help in the development of new drugs so that trials can be eased out and new drugs can be brought in the market easily. Next, I will like to share that AI has gained importance in last few years. As we can see, GIE, that is a very renowned journal, and TIGE, they're very renowned journals, have dedicated their whole one edition for artificial intelligence, and studies are being done all over the world for AI. So, if any trainee or if a GI trainee or and junior investigators are interested in artificial intelligence, then this is the correct time. So gastroenterology research community and AI research community, they both are working so that there is a lots of growth opportunity, so that the science of telemedicine and science of AI can go ahead. So as we can see, for the future, there were the human intelligence, there is an artificial intelligence. Now there is a phase when we are overlapping each other. Then there will be a phase when the machines will take over, and but the softwares, the catch here is the softwares are made in a way so that they don't overtake the human intelligence. But we have to be careful that we develop such softwares so that they don't harm, and the human intelligence can be supported but not overtaken by machines. So the ultimate AI device, what we want is for the future, which is widely available, which is non-invasive, which is definitely inexpensive because it should not involve too much of cost also, and it is well tolerated. So a simple AI software that is made, an example of that is for IBD, there are biosensors available in the toilets, which sense that the patient's pulse, the biosensors, when the patient sits, it picks up the motions in the stools, it picks up the amount of blood that is there. As a result, the grading of the disease can be done. So overall, AI, but technology overall will play a significant role in raising the bar in research and clinical practice in GI diseases. The driving objective is the disease control. Changes are coming sooner than we think. Precision medicine is not pie in the sky. It's all more about how far along the spectrum can we get. Technology won't replace physicians, but physicians who embrace it will replace who don't or who won't. So we have to, with changing time, accept the technology that will help in augmenting our intelligence. Thank you very much. So our acknowledgement to Dr. Michael Wallace, Michael Repisi, Dr. Repisi, and Dr. Brin. Thank you very much.
Dr. Hardik, it's very interesting presentation. I myself have a lot of questions, but I will invite the question from the audience. Yes. Is there any question from the audience? If not, maybe I will try to have a intriguing questions. Yeah. This is very interesting, and yet, but the artificial intelligence, it needs to be supported by the data, the big data of photo, the big data of video, so they can learn and then can generate a good algorithm. So can you share about the process of making it before you finally can have very good tools, tools with higher accuracy? Please share your experience.
Yeah, thank you very much. It's a very good topic actually. What we are doing, as you told, very important, the big data. The data is the most important key, and as we go in future, the data will be the main factor. So we, in our process, we record the videos through the special processors that we have, and as we record, there are certain criterias. Then we, through the communication, we upload those videos over a cloud. And those videos are processed by a whole team which is working, that is a Satisfy Health in Canada. They analyze those videos, and based on those videos, they have seen previously, as we used to record the images. So if we record the videos and send them, they can get multiple images out of that, and that will help in precision of making the AI software. So it has been seen that only images are not very good. if we have the whole recording of the video, like we record every video that is less than 14 GBs, and we upload it, and that will help in making the AI software. So we have recorded almost around 200 to 250 videos, and as a result, the AI software has been made, and that will come in the market soon. And we will validate those videos on few other 20-30 videos, whether it is picking up properly or not, and that will help in more and more accurate precision of the AI software.
Yeah. Sometimes the AI process, like neural network, it has like a very complicated algorithm, so we cannot track. So how is the process that you can convince the physicians, the doctors, that the algorithm is logic in the health content? So
that requires a lot of experience, a lot of teamwork, and the team that we are working it is they are all specialized engineers who have been working with Microsoft, Google, and they have experience with that. And especially the AI, the AI videos that have been analyzed are being done by a team of experts. So Dr. Simon Travis, who had suggested the UCEI scoring system, he himself is involved in the project, and he himself analyzes the videos. So as a result, if there is an experienced backup team of, like we have an experienced backup team of AIG in general, so then we can give them the convincing results. And then, as I told, we will validate those AI softwares on few videos and show that how properly it is working. So that is how we can do it. So experience is the key.
Okay. Any other question, Mr. T?
Is there any program, because for right now, our medical profession try to adapt the AI technology, but what about a patient? How do we build the confidence for the patient so they have, in the future, I think AI definitely is many people area will use it. But what about patient? Do we have any education program?
We have a education program, a public-private partnership also, and also Indo-Japanese collaboration is there, in which we train doctors on the Olympus, like it's a project with Olympus. So we train doctors how to use the AI software, and also we have a team who, like in all the projects that we are involved, when we are doing any procedure on the patients, we explain them. So it's basically the team that comes in that is involved in training, and the explanation to the patients is done by the team. So definitely we have, it is very important that we explain them, but it will take some time so that the patients also realize how effective it is. And it in general reduces the healthcare burden. So if we just remove the polyp and send it, discard it, so the extra added cost of pathology and imaging will be saved. So it will take some time, maybe 10 years down the line, but it will be accepted, definitely. It's the way out.
Thank you very much.
Thank you, sir.
I think Mr. Satya raised hand. So
no,
you want to raise it?
Dr. Arya, now we have Dr. Roman also from Russia joined. So he is in place of Nikonov. Dr. Nikonov some issues. So maybe you can invite Dr. Roman to share their experiences.
Yeah, please,
Yes.
Dr. Roman.
Yes, thank you so much. Dear colleagues, dear chairman, it's my great pleasure to join this telemedicine conference, and unfortunately Professor Nikonov still not available this time. He's a vice prime minister of Khabarovsk region, and he is responsible for social and healthcare issues, and he's solving some problems with healthcare, and asked me to say hello to everybody of to our experts, to our participants, and say sorry, but because he's not able to join you. The situation is in Russia now is not so good. We have about 33,000 new cases of coronavirus, per day. And of course, this is quite challenging for a healthcare system in Russia. And let me highlight the main issues of telemedicine solutions in the era of coronavirus in Russia. So if patients ill and the patient with coronavirus need to be isolated, and we have a lot of patients with a new infection, and there is no chance to hospital to go to hospital there. And as we know, it is very important to know what is the time for hospitalization of such kind of patients. And according to the worldwide experience, there is no clear course of coronavirus, and patient maybe patient in few days should go to hospital and go into some medicine. So we need to follow patient every day, and maybe not every day, twice a day, 3 times a day, and it's quite impossible for doctors in healthcare system. So one of the good solution in this case was to organize the healthcare platform, telemedicine healthcare platform, and one of the state bank of Russia, Sberbank, organized some healthcare system, telemedicine system. It calls Sber Zdorovye, so it translated as Sber Healthcare. So it is very it is robotic system of ongoing contact with the patient. System call patient every day and ask the formal question, and all answers are collected and monitored by the healthcare system. And if there are signs of changing of disease course, doctor called him by himself and ask about hospitalization and ask about some changes in medical care. So this system are available in some regions of our country in Russia, and it works quite well for monitoring of this very difficult group of patients. And of course, at the initial time of the pandemic, we had a lot of consultations, telemedicine consultations with doctors abroad, and of course, many thanks to Dr. Shao. He is the chief infectionist of China. We contact him by telemedicine technologies for developing official Russian guidelines on the treatment of coronavirus. So the situation is not so good, but we have interesting solution like telemedicine healthcare platform. But another issue is education, and of course, all educational program became online, became remote, and one of the program was supported by TEMDEC, and it's my pleasure to be the part of the TEMDEC teleconferences. We have a teleconference with TEMDEC and Russian clinical centers for 5 years, and this pandemic era is was quite difficult to organize side-by-side conferences, and therefore we use this telemedicine system for education of doctors, and education was continued. So thank you so much for your kind attention. I have a very short talk about the situation in Russia, and many thanks for your invitation to this conference. Thank you.
Thank you very much. So I think our time is up for this session. Actually, this is the final session for today's program, and let's give a big hand for all the speakers, okay? And now, Arya, do you have any final comment?
Yeah, it's good that we already we use the telemedicine to solve the problem that we have, especially for what Dr. Roman shared, yeah, that it's contribute to the process of the educating the people, but also for the treating the COVID patients. Yeah, we're sharing experience, especially in international context, learning from the experts from Chinese. So from what I heard, yeah, it's very important. It's good that we share our experience here, and I believe that it will give our improvement for the health management, especially facing the COVID era. I think Mr. Satya raised hand again.
Nothing. Just I wanted to thank Dr. Roman for taking out his time during this crisis. So we know how Russia is now again troubling impact of COVID. I hope they recover fast, and vaccination program also should go well. Not be any major outbreaks again after this.
Okay, so Satyas, is your final comment for today's program?
Yeah, thank you very much to all the speakers and the moderators, TEMDEC, for making this first day program very interactive and very informative. Really, the wonderful sessions we had today. We had world-class speakers who delivered their experience. Maybe can I have remarks from TEMDEC team, Professor Moriyama and Dr. Ko? You are on mute, sir.
You're muted. You're muted.
Sorry, I will make a closing remarks tomorrow, so that I suppose that today is Kriko's turn.
Yeah, it's only interaction between all the participants. Yeah.
Yeah, thank you very much for your wonderful discussions and presentations. And also, I'm happy to see you again on the internet. Dr. Arya and Dr. Jeff and many, Dr. Shirajan, yeah, many engineers. And tomorrow we'll start same time, 9 a.m. in India time. And tomorrow is a kind of engineering program regarding some training or troubleshooting experience or some activities updates from the engineers. But we are very happy to invite, of course, the doctors and the coordinators. So thank you for your wonderful talk today, and see you tomorrow.
Tomorrow.
Thank you.
Yes, see you tomorrow. Thank you so much.
See you tomorrow.
Thank you. See you tomorrow.
See you tomorrow.
Bye bye.
Bye, everybody. Thanks.